4,500 euros. So you can see the difference. Not only it affects the morbidity, mortality, length of stay, ICU admissions, it also increases the cost to the patient. So there are several misconceptions in clinicians about pre-operative anemia. So I will focus on just a few important misconceptions. Sorry. So what people think is that the prevalence of anemia in surgical patient is similar to the general population. So what is great about it? जो जनता में जितना anemia है उतना ही तो surgical patient में होगा. No, this is not right, because surgical population in developed countries, they are found to have exceeding prevalence among of anemia, prevalence of anemia than compared to general population. So incidence of anemia in patients undergoing surgery or about to go to surgery, the incidence of anemia was higher. Another misconception: preoperative anemia poses no risk to the patient. And scheduled procedure, elective procedure should not be delayed. एक पेशेंट हर्निया के लिए आ गया, इसका हीमोग्लोबिन 10 है, क्या फर्क पड़ता है, कर दो ना. क्या 10 ग्राम तो यार बहुतों का होता है, मेरा भी 11 ही तो है, क्या फर्क पड़ता है. ये सभी सोचता है, मैं भी ऐसा ही सोचता हूँ, कोई खास बात नहीं है. बट डेटा कुछ और ही बयान करता है. ठीक है. Preoperative anemia poses no risk. No, preoperative anemia is independently associated with worse clinical outcome. Even mild anemia and appropriate evaluation and treatment may be required. It may require rescheduling. अरे हर्निया यार आज ऑब्स्ट्रक्ट नहीं हो रहा है, 3-4 महीने बाद कर लो, पहले उसका बिल्डअप कर लो, आयरन डेफिशिएंसी ठीक कर दो, B12 डेफिशिएंसी ठीक कर दो, क्या फर्क पड़ जाएगा. Then there are several other factors which we may discuss in between, but then what the data suggests is it's better not to conduct the elective surgery in preoperative anemia patients. It's better to correct the anemia and then reschedule the surgery. Another misconception among clinicians is IV iron is hazardous, associated with a lot of complications, and should only be used for treating severe preoperative anemia. No, this is not right, because IV intravenous iron, it allows a rapid and more complete hematological response and to replenish the iron stores. Okay, so side effects are generally minor, but then benefits are more predictable. So this is another misconception. And one more, that should other transfusion alternative be implemented, preoperative anemia management is not needed or is not a priority. Say, for example, other measures. What are the other measures? Say, for example, this normovolemic hemodilution preoperatively or cell salvage intraoperatively. Cell salvage में क्या करता है? Intraoperatively blood loss होता है, surgeon उसको suction करके सेल वॉश करके वापस से पेशेंट को चढ़ा देगा. तो यार हम प्रिजर्व कर रहे हैं, ब्लड लॉस नहीं होने देंगे. तो देयर इज नो नीड टू करेक्ट प्री-ऑपरेटिव एनीमिया. और या एक्यूट नॉर्मोवोलेमिक हीमोडाइल्यूशन, एएनएच में क्या होता है कि प्री-ऑपरेटिवली पेशेंट का मान लो 11 है, 1 यूनिट ब्लड ले लिया उसका और उसको क्रिस्टलाइट देके उसका वॉल्यूम करेक्ट कर दिया, एंड देन इफ रिक्वायर्ड द सेम ब्लड इज ट्रांसफ्यूज्ड टू द पेशेंट. बट दिस इज अ मिसकंसेप्शन, बिकॉज अगेन whether you are resorting to other measures, alternative measures, but still the benefit are profound if the preoperative anemia is managed properly. So in overseas, the new concept is preoperative anemia clinic. Just like pre-anesthetic clinic, they have now preoperative anemia clinic. Why is it important? Because simple and less expensive treatment for reversible causes are available. आयरन देना है या B12 देना है, मोस्ट कॉमनली तो न्यूट्रिशनल ही होता है, तो वो देना है. इट इज वेरी सिंपल इकोनॉमिक वे ऑफ करेक्टिंग एनीमिया एंड अवॉइडिंग ट्रांसफ्यूजन. इट अवॉइड्स ट्रांसफ्यूजन एंड एसोसिएटेड कॉम्प्लिकेशंस. So preoperative anemia clinic, it implements an anemia walk-in clinic. It's just a walk-in clinic. It is helpful to centralize. It is a centralized OPD clinic, and it is the idea is timely management of preoperative anemia. It is a visit to the walk-in clinic might be made part of clinical routine. Patient is posted for surgery. Patient was found to be anemic. Then patient is referred to the preoperative anemia clinic. And thus the other department like surgery and anesthesia people, they are not burdened with extra workload. They don't have to manage anemia. Only it will be managed in the preoperative anemia clinic. So this concept is prevalent now, and many hospitals, they have the preoperative anemia clinic. So when the patient arrives in the surgery clinic, surgery is scheduled, patient goes to the pre-anesthesia clinic, all the systemic and this problems are addressed, any associated morbidity is evaluated, and then patient is referred to the anemia clinic, where the cause of anemia is investigated and it is corrected, and then the elective surgery is scheduled. But does it make any difference? this pre-operative anemia clinic, does it make any difference? कोई फायदा हो भी रहा है या बस हम ऐसी हवा में बातें कर रहे हैं? नहीं, ऐसी बहुत सारी स्टडीज हैं. We have several studies in which it is found that treatment through a pre-operative anemia clinic is associated with reduction in perioperative red cell transfusion in patients undergoing orthopedic and gynae surgery. As you can see, the RBC transfusion in control patient was it was 26% patient received blood transfusion, but patient who went to PSC clinic, anemia clinic, it was only 12%. Only 12% of patients received blood transfusion. Similarly, in gynec surgery, hospital length of stay was 1 day in but ये है कि suppose were treated at anemia clinic, it was a significant difference.
इससे बेटर ही चले जाओ कि मैम आप आए थे मैं नहीं थी, आप कुछ कहना चाह रहे थे कैसे? मैंने किसी को नहीं बताया था मैम. अनुराधा आई थी ना, तो अनुराधा पायल को ढूंढती हुई आई थी, तो अनुराधा से तुम बात कर ही सकते हैं ना. जारी तो है,
प्लीज
पूछो कि आप आए थे और मैं थी नहीं, आप कुछ कहना चाह रहे थे बस.
All the online delegates, please switch on.
ना अगर बुरा है और अच्छा है तो एक बार सुन लेना, तो कम से कम आप ड्यूटी पे तो कंसंट्रेट करें. नहीं तो फिर आप बार बार परेशान हो रहे हो, क्या लिखा होगा, क्या बोला होगा, क्या किया होगा. यार देखो, जो होना है. सपोज उसके अगेंस्ट कुछ और हुआ है, हाउ यू कम टू नो ना. इससे बेटर है कि जो है एक बार पता कर लो, फिर आगे बढ़ो ना.
चलो खत्म.
खुद से चले जा कि आप आए थे परसों, मुझे ढूंढ रहे थे, तो वहाँ बताया स्टाफ ने. इससे बेटर ऑप्शन क्या?
वो माइक म्यूट नहीं करने तो कुछ नहीं होगा.
उधर से कर दो ना, आपका कंट्रोल आपके हाथ में होगा. चलो ठीक है, ऐसा ओके कर दो.
जूम मैनेज
कुछ हो ही नहीं रहा है.
सर होस्ट उसको बना रखा है, होस्ट किसको बना रखा है?
यही होस्ट था पहले, चेंज हो गया बीच में।
कौन सी में मैनेजमेंट ऑफ पीपीएच?
मॉडिफाइड पीपीएच नहीं ठीक है। हाँ
ये है ना?
हाँ
मैंने कंट्रोल सी कर वो इसमें पेस्ट कर
किनका है सर वो खोल देगा इसी से
अभी अभिषेक डॉक्टर अभिषेक का है ना
04 एंड में
04 नहीं है मैडम, कौन सा नंबर में आपका याद?
मेरा पोस्ट लंच है।
पोस्ट लंच कर देना 00 मत तो जस्ट
हटा दो अभी, है ना, बाद में कर दूंगा।
डॉक्टर चारू लिख दो शुरू में, ये नेम में डॉक्टर चारू, सॉरी जस्ट पूरा क्लिक करो एकदम होम दबा के डॉक्टर चारू स्पेस
जाएगी ना, चेक करने की तो जरूरत नहीं है ना।
चेक कर लेते ना मैं,
नहीं आ रहा
इसमें नहीं है।
ठीक है। सर स्क्रीन कौन से शेयर करनी है अपन?
ये वाला निकाल दो।
ठीक है।
स्क्रीन जो शेयर करनी है वो जो वहाँ पर दिखेगा उसको शेयर कर दो।
उसको करें? चलो लॉन्च मीटिंग
अभी करें या डॉक्टर
कर लेते ना, तो अपने हिसाब से ये होगा ना।
आप फिर से खोलोगे? ये नया खुल रहा है, ये बंद कर दो, खुला हुआ है
हाँ, एक
नया क्यों खुल रहा है?
ये बात सही है।
फंस गया।
कैसे कर सर?
हाँ
ठीक है।
सादिया
ये है
साइनिंग कर पड़ेगा, साइनिंग तो हो चुकी है ना।
साइनिंग तो हो रखा है, लेकिन सर ये वो जो ऊपर वाला था वो नहीं आ रहा है।
क्यों नहीं आ रहा? होस्ट वाला नहीं आ रहा, मेरा लॉगिन कर दूं? काम करो, जूम खोल,
होस्ट तो आपने उसको
इसको
बता
होस्ट कर देंगे, मैं इसको होस्ट कर दूंगा, मेरा लॉगिन यूज कर लो। मैं होस्ट हूँ तो तुम ब्राउजर में चले जाओ, जूम में लॉगिन में जाओ। हाँ, सही मेरा सही।
वो अगर इसमें हो गया है तो क्या करेंगे उसको?
बाकी सबको म्यूट कर दो ना, होस्ट छोड़ के।
आपके पास एक और लैपटॉप होता है, आप पोस्ट करके कहीं पे भी करते रहना पड़ेगा।
अब होस्ट हो गया, अब इसको होस्ट कर दो राकेश, मैंने लॉगिन कर दिया, अब होस्ट ले लो, टेक ओवर, उससे होस्ट टेक ओवर करके।
वो सर क्या है वो?
सिर्फ होस्ट को नीचे से होंगे तो बेहतर होगा सर।
शिवाल से बात कर लो
सर, क्योंकि कुछ कर सकते हैं सर, आप होस्ट हो जाइए।
आप तो है ही।
मैं ही हूँ,
आप ही होस्ट है ना सर?
हाँ, तो उसमें भी मैं ही हूँ, इसमें भी मैं ही हूँ, दोनों में हम लॉग्ड इन।
होस्ट एक ही रखते हैं ना सर, वहीं से
हाँ।
नीचे से ही रहेगा।
नीचे से होस्ट रखोगे तो जो भी है यहाँ से वहाँ ट्रांसमिट कैसे करोगे, क्या करोगे? एक बार शिवल का क्लास चल रहा है, एक बार पूछे, वो 11 से उसका क्लास है।
लोगों आइडिया सर आपका
ये आवाज किसकी आ रही है? हमारे आवाज
का ये एक्चुअली डैश
अच्छा डैश का आ रहा है, ठीक है।
डैश को भी म्यूट कर दूं,
डैश इज अस,
ओनली दिस विल बी ओपन एंड ऑल दिस विल
नहीं डैश को म्यूट मत कर क्योंकि डैश का ही आवाज रिकॉर्ड हो रहा है।
लेकिन सर आपने होस्ट यहाँ पे ओपन नहीं करना था, आपने होस्ट में रखना था।
होस्ट उसी को रखना,
इसको हटा दो।
एक सेकंड शिवाल, ठीक है तो होस्ट हटा दो इसको। तो वो तो दोनों ही मैं हूँ, तो होस्ट तो उसको रखा हुआ है ना, इसका होस्ट का
वो सर फिर
दोनों भी लग
वो लूप हो जाएगा ना सर, वहाँ तो लॉक होस्ट उसको बना रखा आपने।
नहीं, उसको इसको ऑन रखो।
इसको ऑन रखेंगे तो जाएगा ना, जो प्रेजेंटेशन देने आएंगे।
नहीं तो उसको
नहीं म्यूट वहाँ पे एक काम करते हैं,
सिर्फ ये छोड़ के बाकी सबको वो कर दो, बाकी सबको म्यूट कर दो ना, ओनली दिस विल बी ऑन। बाकी यहाँ तो लोग दूर है, यहाँ तो लोग आराम से करेंगे। सिर्फ स्पीकर का खुद का हल्का सा फीडबैक होगा बस, तो नहीं होगा ना
सर। आपका दो चल रहे हैं सर, ये डैश का है, डैश का ओपन है,
डैश इज मी, दैट इज
इसको मिनिमाइज कर दो सर यहाँ से।
हाँ कर दो।
ये तो हो गया वैसे भी।
हाँ
अभी 1 मिनट इसको भी मिनिमाइज कर लेते हैं। अब अपन चेक कर लेते हैं सर, जैसे किसकी है अभी, इनकी है।
नहीं डोंट म्यूट दैट वन,
अनम्यूट कर दिया। अब आप चेक कर लीजिए।
हां म्यूट दैट वन, विल अनम्यूट दिस वन।
आ रहा है सर, टॉकिंग डाइज आ रहा है।
हां डैश म्यूट, डैश अनम्यूट,
टॉकिंग डाइज आ रहा है।
हां टॉकिंग डैश, हां डैश टॉकिंग एंड दैट होस्ट इज म्यूटेड, होस्ट को म्यूट कर दो।
जी ना कंट्रोल क्यों नहीं खुल रहा है? खुल नहीं दिया नहीं यार।
वो तो खुल्लूड़ा था कटिंग का मिनिमाइज यूड़ा अटीज कटिंग खुल्लूड़ा है जान में दिखा रहा स्क्रीन शेयरिंग स्टार्ट ओके नो स्विच switch
हेलो और कर दिया वो रिकॉर्डिंग स्टार्ट कर दो हेलो सर हेलो वही आ रही है बेटा हेलो 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 सर चेक हेलो 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 इनेस आएगी बेटा लैपटॉप देख स्लाइड चेंज हुई
We welcome you all back. हमारा अगला साइंटिफिक सेशन अनीमिया मैनेजमेंट के ऊपर होगा। इस सेशन को चेयर करने के लिए और स्पीकर्स को इंट्रोड्यूस करने के लिए हम स्टेज पे बुलाना चाहते हैं डॉक्टर मंजू मोरा मैम, हेड ऑफ द डिपार्टमेंट ऑफ ट्रांसफ्यूजन मेडिसिन, एसएन मेडिकल कॉलेज जोधपुर, और डॉक्टर देवराज आर्या सर, एडिशनल मेडिकल डायरेक्टर जयपुर। We welcome you sir, we welcome you ma'am. Thank you, sir. Thank you, ma'am. Now we humbly request both of you to take over the session.
Speaker, Dr. Rbc Production, as Department of AIIMS JodhPur. He will give us lecture on all anemia stage.
Namaskar. Thank you, sir. Thank you, ma'am. First of all, I thank organizers for inviting me to a lecture on the topic all anemia same and insight. क्या बोलते हैं आप लोग? Are all anemia same? Yes, no, can't say. Or no with partial yes. A person sitting in Ukraine might think all Indians are same. But we know that all Indians are not same. We are different by our culture, eating habits, language, right? So similarly, if we are looking at anemia को बाहर से देखें तो we can think yes, all anemias are same. But no, it's not true. It's a sign of an underlying disorder. It is not a disease. And in next 19 minutes, I will be covering this topic in 10 top points. And we will try to see what are the similarities between different looking things and what are non-similarities between similar looking things. So let's start with the point number 1, cutoff. Anemia कब डिफाइन करेंगे, कैसे डिफाइन करेंगे? हमारे पास कट ऑफ है हीमोग्लोबिन का, and this cutoff is also not same for all. Like you can see, this cutoff is not same for Abhishek Bachchan, his wife, or his daughter. How? We will see. How it is defined? Anemia is functionally defined as an insufficient RBC mass to adequately deliver oxygen to peripheral tissue. This is what we are taught in Robbins. It's not practically possible to measure RBC mass. So generally we measure 3 things, either hemoglobin, hematocrit, or RBC concentration. If you go by WHO definition, anemia is defined as condition in which there is a decrease in the number of RBCs or their oxygen carrying capacity, which is insufficient to meet physiological needs. Again, you can see the need word red mein hai. This need is also not same for all. So this can vary, it change ho sakti hai with the age, sex, altitude, smoking, pregnancy status. So within definition, we can see there is no uniformity for all. If we talk about cutoff, when do we define anemia? In an adult male, we say person is anemic when the hemoglobin level is less than 13 gram per deciliter. In an adult female, we say lady is anemic when the hemoglobin is less than 12 gram per deciliter. And a pregnant lady when the hemoglobin is less than 11 gram per deciliter. These are very important because these values are not same when we are talking about children. A pediatrician, when he or she is looking a case in his or her OPD, cutoffs are different, like 11 gram for 0.5 to 5 years of age child, 5 to 12 it's 11.5, and from 12 to 15 it is generally considered 12 gram per deciliter. Second point, all anemias are not pathological. Generally, when we are talking of anemia, a person from pathology is discussing, we think all anemias are pathological. No, a few are physiological also, like physiological anemia of infancy. We have checked that the anemia definition is 11 gram per deciliter at the age of 1 year, but we know a newborn is generally having 18 gram per deciliter hemoglobin, 17, 20, sometimes 22, sometimes 15. The cutoff is 14 gram per deciliter for newborns. So why this decrease in hemoglobin till 1 year? This is physiological anemia of infancy because of certain physiological changes. Similarly, in the pregnancy, because of the increased demand. There is increase in RBC concentration. At the same time, there is increase in plasma volume. So there is dilutional anemia that is also physiological. Point number 3. All anemias are not acquired. Like we know that iron deficiency anemia, the person is having poor diet. Diet सही नहीं है, iron deficiency होगा, diet सही नहीं है, vegetarian है, vitamin B12 deficiency होगा. But all are not acquired. There are anemias like thalassemia, sickle cell anemia, they are inherited. So all anemias are not same in this respect also. The point number 4, that is underlying mechanism. So if we look at mechanism, there are 3 possibilities. Either there is decreased RBC production, increased RBC destruction, or increase in the blood loss. There is blood loss, right? So if we go further deep down, there is a list of various other underlying causes like RBC production. It can be decreased because of the genetic defect, nutritional deficiency की वजह से, body के अंदर कोई coexisting disease है उसकी वजह से, or there might be something in the bone marrow. Bone marrow is occupied by some other lesion. So there are several causes for decreased RBC production also. So bone marrow suppression, especially involving RBCs, can be because of several causes. Increased destruction, we know hemolytic anemias. Hemolytic anemias, they have several causes, underlying causes. They can be immune mediated, non-immune mediated, at times mechanical, or because of some drugs. Blood loss, it can be acute blood loss or chronic blood loss. And chronic blood loss, it's very slow and it's sometimes tough to identify. So we should know all these causes when we are dealing cases in our practice, and maybe at primary healthcare center or in community health center. We should know if a case of menorrhagia is coming with anemia, the cause might be in the somewhere in the disease. Prevalence wise also anemia are not same. Few anemias like iron deficiency anemia, they are posing a major public health problem, quite common. If we talk of Jodhpur, in children up to 5 years and in pregnant ladies, it is common, and it is accounting for 40% or 50% of all anemias. Whereas other anemias like a name you must have heard, congenital dyserythropoietic anemia, it is very uncommon. So anemias, few of them may be very common, few of them may be very uncommon. Clinical features. So there are certain features. We all know case of anemia, the person who is having anemia will present with weakness, fatigability, general malaise, shortness of breath, palpitation. Older patients, they can have congestive heart failure. When we look at them physically, they may have pallor. These are common symptoms and the signs. But if we go deep, we can understand that there are changes, there are differences between various anemias. Like history can also tell us if there is rapid onset, trauma-associated anemia. It is definitely because of acute blood loss that may be external or internal. If not external, we should search for internal cause. At times, iron deficiency, we know in pregnancy, in growing children, they are having predilection for iron deficiency anemia. Those who are having pica, atrophic gastritis, glossitis, nail changes, that is koilonychia. So by looking at physical signs and symptoms and history, we can also identify. Akela anemia, that can be okay. But when anemia is associated with other things like bleeding, high-grade fever, we have to think of acute leukemia also. So again, all anemias are not same. I will go on speaking the same line. All anemias are not same. If they are presenting with jaundice, we have to think of hemolytic anemia. Generally, occupational history can also give us a cause. If there is some oxidant chemical injury, the patient is having splenomegaly, can have some neoplastic disorder like myeloproliferative neoplasm, CLL. Skeletal changes hai, dwarf hai, baby, or there are some skeletal changes. We can think of bone marrow failure syndromes also. So clinical features can also help us if the patient is having jaundice, splenomegaly, gallstones. We have to think of hemolytic anemia. If the patient is having such phases on the left, extreme left, It is peculiarly seen in thalassemia. Thalassemic facies is the name what we give it. Leg ulcers sometimes seen in sickle cell anemia. On the lower right side, a typical picture of Fanconi anemia, case of Fanconi anemia. There are skeletal changes, short height, and facial changes. Koilonychia, when spoon-shaped nails are seen, we can think of definitely iron deficiency anemia. You might get such cases in your surroundings. People are eating mud or ice or chalk, something which should not be eaten. The name given to this condition, that is craving for non-food substances, is called pica. Pica is a bird. That bird can eat anything generally. So we have given this, not we, experts have given this condition as name as pica. Sometimes we have very typical findings for various hemolytic anemias, like a male neonatal case with the neonatal jaundice. After exposure to some Occitan drug, we have to think of G6PD deficiency and investigate accordingly so that we know the cause of anemia. A child is coming with anemia, jaundice, family history of jaundice, and splenomegaly. We have to think of spherocytosis, and we have to check all laboratory details. I will skip this further. Next point, ethnicity. We have seen the Indian subcontinent. It's full of various ethnicities, and a few anemias are common in one particular group of people, and others are having some other kind of anemia, like beta thalassemia is common in Punjabis, Sindhis, Jains, Bhanushalis, and some of the Jat Sikhs. Alpha is common in Southeast Asia, whereas sickle cell is common in the central and the southern part of India. If we talk of Rajasthan, it is common in the southern Rajasthan, in Banswara, Dungarpur, Udaipur, Siroi area. So we should know which anemia is common in which area. So ethnicity-wise, anemias are not similar. 7th point, laboratory features. We know most of them are having low hemoglobin, but only hemoglobin decrease is not required to label subtype of anemia. What else we require? CBC. It is available at every center, even in the primary health centers. I think most of the primary health centers are having facility of CBC. If not, the laboratory network is very prompt, and now we can do it. Simple, affordable investigation with which provide mammoth of information. Commonest test. What do we get? We get red cell indices, we get hemoglobin, hematocrit. Now we have very automated instruments, and we get quickly reports. And this picture of Winthrop, if we talk of hematology, we should know Winthrop. He gave calculation of indices. With the help of these indices, in indices की वजह से MCV, MCH, MCHC हम anemia को further classify कर सकते हैं. Next thing, important thing is reticulocyte count. जब भी anemia case हम deal करते हैं, we should get CBC done as well as peripheral smear examination and reticulocyte count done. So we can classify anemia properly, because whenever we are seeing anemia, we have to see कोई और condition है क्या साथ वाली. If there is something else also, we have to do bone marrow examination. If no, then we have to first check reticulocyte count. If the count is high, means bone marrow respond कर रहा है. The causes might be due to blood loss or because of hemolysis. So we have to investigate that way. If not, then we have to resort to CBC and peripheral smear examination. Peripheral smear examination, gold standard. Never miss this. Get this done from your pathologist, or if you can learn, you should also see in CHC, in PHC. If you do not have facility, you must be having backup of blood bank. Get it done. How does this help? It helps us in dividing anemias into macrocytic, or normocytic anemia. Further, macrocytic anemia, not all are iron deficiency anemia. There may be iron deficiency anemia, thalassemia, sideroblastic anemia. Again, we have to investigate it further with the help of reticulocyte count. फिर biochemistry के investigations होंगे. For example, serum transferrin saturation, serum ferritin, serum iron levels. If this is not helping, next investigation in microcytic hypochromic anemia should be hemoglobin HPLC, जिसको हम commonly hemoglobin electrophoresis बोलते हैं, to check whether the case is having beta thalassemia. Macrocytic anemia, नाम से पता चल रहा है, big RBCs. So what it can be again megaloblastic or non-megaloblastic. Macrocytic, we think vitamin B12 deficiency or folate deficiency, but there are several causes. Apart from this megaloblastic, we can have several causes like hemolytic anemia, post-hemorrhagic, sometimes bone marrow failure syndromes, liver disorders, MDS. Those are less common in common practice, but we should know all these cases, all these causes. And macrocytic anemia, again, when we are starting the investigation, we will start with peripheral blood smear examination. We will check reticulocyte count. Based on the count, we further investigate and try to find out the cause. Peripheral smear examination can help us identify. You can see there are pictures. These are fragmented RBCs. These are seen in thrombotic microangiopathies. We can see clumps. Very easily can be picked up on the peripheral smear examination and macrocytic blood picture. So PSA is very important. Normocytic anemia is also not uncommon. So what are the causes? It can be because of post-hemorrhagic anemia, hemolytic anemia, bone marrow failure syndromes, at times with the early iron deficiency. Again, with the help of reticulocyte count, we try to further classify normocytic, normochromic anemias. If there is increased reticulocyte count, always start hemolytic anemia workup. That would include LDH, indirect bilirubin. You should get complete LFT done along with LDH. These all will be increased with the increased reticulocyte count. And then we have to check for cause of hemolysis. DCT, ICT is also to be complemented with this. So we can see that modalities required for diagnosis of anemia is also not same. Few of the investigations, CB6 सभी में करना चाहिए, PBF, reticulocyte count, hemolytic workup, DCT is okay. But सारे anemias investigate करना है तो you need more. You need further workup, nutritional anemia. You need to get serum ferritin levels done, serum vitamin B12, folate. B12, folate के लिए it's better we give therapeutic trial rather than investigating, because B12 folate levels, they have their own lacunae. Hemolytic anemia workup. And after this, we have to do hemoglobin HPLC to detect beta thalassemia or sickle cell anemia. We need to diagnose this. We have heard the name of hereditary spherocytosis. For that, we need to do osmotic fragility testing. And with these inherited disorders, frequently we have to do family testing also. केवल इंडेक्स केस का टेस्टिंग से नहीं होगा, वी हैव टू चेक पेरेंट्स ऑल्सो. कुछ इन्वेस्टिगेशंस फर्दर, बोन मैरो एग्जामिनेशन. आप सोचेंगे कि एनीमिया के लिए बोन मैरो एग्जामिनेशन, बट देयर आर एनीमियाज लाइक प्योर रेड सेल एप्लेजिया. विदाउट बोन मैरो वी कैन नॉट डायग्नोज. डेफिनेटली वी आर नॉट गोइंग टू डू बोन मैरो एग्जामिनेशन फॉर आयरन डेफिशिएंसी और a common megaloblastic anemia, but something which is not responding, transfusion dependent, HPLC normal है, hemolytic anemia workup नहीं हुआ, that is normal, then definitely bone marrow required होगा. PNH नाम एक होता है, उसके लिए तो we have to go to flow cytometric immunophenotyping. MDS के लिए cytogenetic study. So there are investigations which are required in workup of anemia. So all these investigations are also not same. Sometimes we have to give some instructions to the patient and their family that they need to do some precautions like drug exposure, like G6PD anemia, G6 deficiency anemia. In this, patients are prone to hemolysis. Hemolysis होगा after exposure to drugs. किसी family में तो even exposure to naphthalene balls can cause anemia. So दो बच्चा जो न्यूबॉर्न होता है उसको पुराने कपड़ों में अगर रैप किया है जो कि नेफ्थलीन बॉल्स के साथ रखा हुआ था, that बच्चों can develop anemia, hemolytic anemia, if that बच्चों is G6PD deficient. So we need to give instruction to the parents. At times with inherited anemias, we have to do genetic counseling also. Treatment is not same. So we need to diagnose anemias properly so that we can treat it differently. कुछ को केवल ओरल मेडिकेशंस चाहिएगा, कुछ को इंजेक्टेबल्स चाहिएगा, and many anemias they require red cell transfusion also, and some anemias are so serious that bone marrow transplantation भी required होगा. Outcome, the 10th point, after all this, outcome is also not same. You can see iron deficiency anemia. If it is a common iron deficiency anemia, then it can be treated with iron supplementation. Whereas G6PD deficiency, you know that you have to give all precautions, instructions, and beta thalassemia major, the outcome is not good as compared to nutritional deficiency anemia. Patients generally require transfusions for the life, and they may have to go for bone marrow transplantation also. So again, in the end, I would ask, are all anemias same? No, they are not same. So we are clear, all anemias are not same. So ये कार्यशाला है एक तरह से ट्रांसफ्यूजन मेडिसिन की. सो वी शुड नो दैट अलग अलग अनीमिया होते हैं, अलग अलग तरह के अनीमिया होते हैं, हमें इन्वेस्टिगेट उनको करना होगा सो दैट पेशेंट ब्लड मैनेजमेंट जो एक कॉन्सेप्ट है उसको प्रॉपर्ली इंप्लीमेंट किया जा सके, राइट. एंड व्हाई शुड वी नो, आई एम फिनिशिंग मैम, जस्ट 1 minute मैम. एंड वी शुड नो, why should we know? Because there are different cutoffs, different clinical features, different causes, different laboratory features, different treatment options. So we should know that there are they all are different type of anemias. Last, with the permission of organizers, I would like to highlight this thing. On 10th of April, we have hematology update that will include, that will focus postgraduates of pathology, medicine, pediatrics, transfusion medicine, laboratory medicine, fellows of hematopathology, clinical hematology. Registration details is given, but all those participants of this workshop can register with 1,000 rupees. The forms will be available on registration desk shortly. Thanks.
Macrocytic anemia, whether it is MCV 96 cm or it is 100, more than 100 cm.
Ma'am, we have to look at definitely what you are saying, CBC. CBC हमें देखना होगा. Generally जो हम कट ऑफ रखते हैं 80 से 96, 80 to 96 हमारा कट ऑफ होता है. Yes, but we. Yes, ma'am, I'm telling you. So हमें बहुत ज्यादा रिजिड नहीं हो सकता मैम, थोड़ा सा लिबरल होना होगा. 96 है, वी हैव टू चेक पेरिफेरल स्मीयर एग्जामिनेशन, फर्स्ट थिंग. सेकंड थिंग, आरडीडब्ल्यू. हम पीएस नहीं देखना चाहते हैं तो आरडीडब्ल्यू देख सकते हैं. इफ आरडीडब्ल्यू इज लेस एंड एमसीवी इज 97, स्टिल वी कैन थिंक दिस माइट नॉट बी a macrocytic anemia. But if you see RDW is 20, 22, 24, and in this case, even if MCV is just 96, 95, 97, even 94, we need to check peripheral smear, because if there is dual deficiency, frequently those who are deficient in one thing, they are deficient in other thing also. Vitamin B12 deficient बच्चा होता है तो chances है कि उसको iron deficiency भी होगा, and mixed anemia can give us a normocytic normochromic picture. उसमें जब smear देखेंगे then only we can identify, yes, there are microcytosis also and there is macrocytosis. So two things, RDW and peripheral blood smear examination. Sir,
मैसेज में देना चाहूँगा कि whenever CBC analysis करें,
sir,
तो always go through the peripheral blood smear with CBC will give more information than
agreed, sir.
CBC.
Agreed, sir. Sir, CBC is important. It is available everywhere, but we always give this message that the PBF is gold standard. We should not omit PBF. That's why I said pediatrics person जो post graduates हैं, they can learn it quickly, so that in cases if they do not have expert pathologist with them, वो खुद से भी सीख सकते हैं, देख सकते हैं. टेक्निकल स्टाफ भी सभी समझते हैं.
एक चीज मैं आपको बताना
सर,
कि बहुत साल पहले डॉक्टर गोविंद मेरे स्टूडेंट थे, लेकिन आज इतना बेहतरीन शानदार ब्यूटीफुल प्रैक्टिशनर एनिमिया मुझको पढ़ा है, मैं उसका दिल से क्या कहूँगा, very nice.
Thank you. Thank you, ma'am.
Your presentation was really, the blood is colorful. Your presentation was very colorful and very informative. Even a person is not listening to you, he or she can understand that what you are telling and what you want to make them understand. Because it was really very colorful and very presentative. So thank you very much. And you have explained everything in a better way. Thanks.
Thank you, ma'am.
Thank you, sir, for your wonderful presentation. We'd just like Dr. Arya, sir, to felicitate our speaker, Dr. Akship Rohit. जैसे सर अभी बता रहे थे कि सारे ट्रांसमिशन कैन इंटरफियर विद द डायग्नोस्टिक वर्कअप एंड इसकी वजह से बहुत सारे पेशेंट्स जो हमारे पास आते हैं इसमें ट्रांसफ्यूजन की वजह से माइक्रोसाइटिक एनीमिया हो सकती है, वो सारे इंटरफियर होते हैं. तो इसीलिए इम्पोर्टेंट है कि पेशेंट का पहला डायग्नोसिस हो जाए, इसके बाद जब तक पेशेंट बहुत ज्यादा सिम्टोमेटिक ना हो ट्रांसफ्यूजन ना करने ही बेहतर है. थैंक यू.
Request Dr. Mandal for his next presentation.
Good noon, everyone. So the topic I'm presenting today is iatrogenic blood loss, an invisible cause of anemia. So let's start with hospital-acquired anemia. So we know from the term hospital-acquired, what does it mean? That means it was not present before the hospitalization and it was acquired during the hospitalization. But is it due to the hospitalization? We'll see very soon. And also we should, when we are dealing with this topic, we should not exclude the people who are already anemic and getting further anemic. So is it the same? What do you guys say? Is hospital-acquired anemia same as iatrogenic anemia? Some people use it almost interchangeably, but do you agree? Or yes, no? No? And why? Okay, that's another term, but
Hospital-acquired is nosocomial. Iatrogenic is just due to the doctor causes the anemia.
okay, right. So hospital-acquired anemia is an association, but not all of it is causality. But when the anemia is caused by the hospital, iatrogenic means by the hospital, by the doctor, or by the treatment, then it is iatrogenic. And so they are not exactly the same. Hospital-acquired anemia is a bigger set, and iatrogenic anemia is a subset of that. And we'll see soon some of the subsets we'll highlight. So hospital-acquired anemia is the bigger set. The subset is iatrogenic anemia, which is caused by the hospital. And then iatrogenic blood loss is overlapping set with iatrogenic anemia. Some of it causes anemia, some of it might cause subclinical anemia, and some of it might aggravate the anemia which is already there. So iatrogenic blood loss is something that is preventable or at least modifiable. And that is our purpose, is to reduce iatrogenic blood loss as much as we can in frequency or quantity. So what are the common risk factors? Early hospitalization, longer hospitalization, extremes of age, extremes of weight, other diseases, and this particular disease for which the patient is hospitalized, if it's severe. If it gets severe, then what happens? It might get critical. And if it gets critical, then what happens? Can you imagine that critical care admission itself is a cause for hospital-acquired anemia? We'll come to it soon. Why? So this is a Canadian study in which they saw 400-500 patients who are admitted in ICU. And within about 2 to 3 weeks, everybody gets anemic. And see people who are, like you see, this is a different unit than our gram per deciliter. This is gram per liter. So people who have like average of 13, they are losing blood at a rate of almost like 50 to 100 ml a day. because of a lot of investigations actually. And the people who are around 11 who are already anemic, so I'm calling it hospital aggravated anemia, that's my term for it, but it's also something to look at. So many of you already know that like most of you are from the blood bank community, right? So you know the blood bank guidelines of AABB. It's written by Jeffrey L. Carson, the first author, the 2016 AABB guideline. The same Carson in 1996 had a Lancet paper in which he showed that anemia is itself a cause for mortality. And Dr. Bhatia showed in far more detail than I'm telling you that anemia itself is an independent risk factor for mortality. And particularly in cardiovascular patients, it goes very steeply high as the hemoglobin goes down. However, like the today's topic is patient blood management, right? So we are going to tell you the other problem, like कुआ versus खाई. तो एक तरफ कुआ तो दूसरी तरफ खाई क्या है कि अगर ट्रांसफ्यूजन देके उसको करेक्ट किया तो that causes even more mortality. So you're not reducing the mortality of anemia by giving transfusion. You might end up increasing the mortality because giving transfusion is another cause for mortality. So then how do we reduce the anemia? By ways as much as possible other than transfusion. So as I already told you briefly that what was the top cause of anemia. So this top cause is actually already listed here. So the frequency and volume of phlebotomies is the top cause for iatrogenic anemia and it's fully modifiable. It's in our control. And are you sensitive about it? No, we often just say कि भाई वो sample थोड़ा खराब हो गया या ये sample लेना भूल गया था उसमें एक दो और टेस्ट ऐड करना तो पूरा एक और sample ले लो है ना. तो that is something which actually causes something which can even cause mortality of a patient. We sometimes think it's तो casually वो है कि एक sample लेने में कितना जाता है I'll come to you soon. So other than causing hospital acquired anemia, which is in red, there are several other problems we cause if we do a lot of sampling. For example, if there is an early morning draw, you can disturb the sleep of the patient. And also every stick causes either anxiety or pain. Or even if it is not a stick, if you are collecting blood even from a line, that can cause even more hospital acquired anemia, which I'm going to explain soon. And that's something which is not given in most of the books that I'll be covering. Plus, unnecessary testing causes a lot of not only the phlebotomy staff, but it's causing preoccupation of the whole laboratory pipeline. And so it's causing delay of the other important tests. If this particular test is unnecessary, and if you have 100 such unnecessary tests, then maybe dozens of very essential life-saving tests might get delayed. All their turnaround times are increasing. And also increased workload is going to cause increased errors. So this is, bathroom saaf karte hai, वैसी चीज ये cartoon है. There are so many cartoons, but what does it mean? What are we talking about here? So hospital-acquired anemia, it is either associated with hospital or it is caused by hospital. But let's see some other associations. So, okay, these associations we have already seen, but this one I told you already, that critical care admission. So see the difference. A regular medicine ward patient gets blood drawn at 12 ml per day average in the Western world. And in ICU, it is about 45 to 50. We have data only from the Western world. There is no data from India. So there are so many causes of hospital-acquired anemia. But the main modifiable one is the laboratory testing, which is in our control or the control of the doctor who's ordering it, or control of even the patient, even the phlebotomists or even the residents who are actually noting down the order. Sometimes they're passing down the order in a wrong sequence. Sometimes they're repeating some of the orders. And so it causes adverse outcome directly through anemia. And if anemia is severe, sometimes we have no choice but to give transfusion. But if we give transfusion, that itself has an adverse outcome, has a lot of adverse outcomes, which is the whole theme of this particular meeting. I don't want you to read this whole thing, but just I want you to notice that this is a 2011 paper. And this was one of the very first paper, which was the quantitative paper on hospital-acquired anemia. Before that, even though for 100 years, we knew that if you draw too much blood, obviously you might cause anemia. But there were very few quantitative papers or analysis on hospital-acquired anemia caused by blood draws. And it showed that, yes, a lot of blood draws is independently associated with anemia and all its morbidities and mortalities. So this is the same Canadian study I showed earlier that shows something unusual. So this is what is not there in most of the textbooks. So when you talk about blood draw and the volume of the blood draw, how much is going to the lab, you guys realize that there is additional blood volume which is being lost. Can you guess where this blood volume is going? Why is there a blood waste or blood There is a term waste here written, this yellow graph. This yellow graph is much higher than the blue graph, right? So the blue graph is what is reaching the lab. But the yellow graph is what is actually being lost from the patient. Where is the rest of that yellow part is going? Vaporizing on the way. Any guess where it is going? ये lab नहीं पहुंच रहा है, कहाँ जा रहा है? Can you be louder? In syringes, that might be minor part, but which syringe? The syringe which is collecting your sample? Or is there any other syringe? Okay, I'll come to it. So the answer is that when you have a sampling in the ICU, have you seen a ICU nurse or ICU resident sticking a patient with a needle? How many times have you seen? Majority of the times you order, actually they do a shortcut. They collect the sample from a line, a venous access device. That can be either a simple cannula, or that can be a central line, that can be arterial line. And in order to draw from a cannula, suppose you have ordered a platelet or you have ordered a coagulation test. What will happen if you get such a sample? If somebody just simply draws that blood and sends to the lab, what kind of result will you get? Let's say you are doing a CBC. What will happen to the platelet count? Decrease, yes. Why? Okay. So if the sample is directly drawn from the line, part of the line which is stagnant, there will be microclots there. And so those microclots have consumed the platelets. So platelet count will be low. Or it might be locked with saline or heparin. So that lock will be diluting the sample. So if you take the part which is stagnant in that tube or cannula, that dead space, if you collect the blood directly, it will give you a wrong value. Not only for platelets, severely bad results will get for coagulation tests. Platelet will be underestimated, and many other tests might be slightly abnormal. So what do people generally do? Any guess? So most of the guidelines, they say that when you take samples from these cannulas or from these indwelling catheters or lines, you're supposed to collect a waste. Why is it called a waste? Some people say that, okay, you take it in a syringe and you push it back. But suppose if it is an indwelling catheter and you push it back, then what is the problem? You take a separate big syringe, 20 ml syringe, you take a large volume of blood and put it aside, and then you collect your sample. Now what do you do with that 20 ml? Will you push it back? If you push it back, you are increasing the chances of line infection, which is itself a cause for mortality. So majority of the places where they draw such waste, they actually call it a waste and they actually waste it. In India, many people actually push it back. So maybe our hospital-acquired anemia might be less for that, but our line infections might be more for that, right? So then what do? Majority of the guidelines, if you look, there are very few guidelines actually. There are only 2 or 3 guidelines in the world which talk about how much blood to take in the West in the first place itself. That in 1994, there were some studies which have been just copied blindly. So I'll come to it, how much blood you are supposed to take in that West. But there were surveys by European Federation for Lab Medicine, EFLM. And the nurses survey, what does it say? Majority of the nurses didn't even know that it makes any difference, that if you draw a waste, it causes hospital-acquired anemia. They were not, most of them were not aware. But they were aware how frequently it is drawn. That survey said 16 times a day, they're sampling from those lines, average. So can you imagine, whatever orders of tests you are giving in ICU, majority of them are coming from those lines. But they know that they have to take a waste. At least in the Western world, they know. So, and what is the concern from the lab? Why don't we want the sample from that stagnant part? Because it can cause hemolysis, it can be contaminated with that lock fluid, it can be contaminated with IV fluid, the last part of the last IV line that went in, or it can severely impact the clotting results because there will be microclots. So WHO 2009 guideline does not touch upon this topic. EFLM 2018 guidelines says new guidelines will be coming which will be covering this, but as late as 2018, the most recent EFLM guidelines, which is even more recent than CLSI, does not touch upon this topic. Just says that their pre-analytic working group is working on it. So, and how much blood is wasted, by the way? Can you imagine the dead space volume you have? You are supposed to ideally remove at least 2 times the dead space for even a regular test. And if you want a very accurate platelet result, or if you want a very accurate coagulation result, 4 to 6 times the dead space is recommended. This recommendation comes from mid-90s. Those are actually not exactly evidence-based, but all the guidelines have blindly copy-pasted those. So there is not much evidence how much blood should be wasted, but people rampantly waste this much blood. And so this is where the blood goes. Only a little bit goes to the lab. A large amount of that blood, that yellow line in that graph, if you remember, is actually going down the drain. So how much volume should you discard? That is 6 times, and that 6 times, if it is a big line, if it is a central line, then 6 times of that dead space volume. And actually, if you calculate along with the connectors, then it becomes even bigger. People who are even more meticulous, like people who are theoretically very good, they might say, okay, that is also dead space, and they will add it in and then multiply by 6. It's a huge amount. So if you want a very accurate coagulation result, the amount of blood you will be losing in a usual technique is that much. And somebody in 2015 did a modeling study and showed that in females it will be causing anemia faster. If the person doesn't have active bone marrow, it will be causing anemia faster. And in the real data also matches those models. And so just like in regular PBM, we say that when you need 1 unit of blood transfusion, like when you are driving bicycle, you wear only 1 helmet, you don't need 2. So when you don't need 2, you don't wear 2 helmets, you don't need 2 units of blood, you don't transfuse 2 units. Similarly, when you don't need 2 draws, when in 1 needle stick and 1 smaller volume, you can do same number of tests, do that smaller number of needle sticks. And so this is already there in choosing wisely. But for example, a lot of companies already have the pediatric tubes. So when you are treating an adult patient, does not mean you cannot collect any pediatric tube, right? So pediatric tubes are called pediatric tubes because they're made originally for children to be collected in the wards. But when you're in the ICU setup, I request all of you to please collect pediatric tubes from your pediatric counterparts and stock them in your wards, in your ICUs, and make sure that the repeated sampling that happens in the ICU are done in pediatric tubes. I'm not showing pictures, but I'm sure all of you know how pediatric tubes look. They may not have a vacuum, they may not be convenient. You might have to collect the blood drop by drop painfully. It might take a little extra time, but it will save your patient probably his life. Similarly, if you don't want to do that, if you don't want to throw the waste, but you want an accurate result of, let's say, your coagulation results. So there are multiple techniques for that also. These are things which are not there in most textbooks. So that's why I'm spending a little time here. So there is one technique which is called the push-pull technique. So first you push. Push means you push in saline, not heparin. Okay. So push saline to clear the stagnant part. Then what do? Can you just collect? No. Because you have just pushed in saline. So that saline has just mixed with your blood. Blood is still diluted with saline, right? Now how will you mix that? So you pull, push again, pull, push again like that 4 times. So now you have mixed the saline enough with the blood. Now you can take your sample. So in India, you can do this, right? You don't need any extra paraphernalia. You don't need any extra special apparatus. But in the West, they have come up with special apparatuses also. We'll come to that. But a quick question. We don't have clickers, but so there are 4 choices here. Anybody wants to guess? What is blood-saving bundle? Okay, it's a trick question actually. So B, C, and D both could be called it, but it's just so happens that one paper and one company called a closed sampling system the blood-saving bundle, which is actually a bit counterintuitive. So the actual answer is C, but B, C, and D all are blood-saving. Okay, so this is one picture of such a blood-saving bundle. It's called a closed, the technical term is closed sampling system. So instead of a push-pull system, if you want to do a actual accurate sampling for a coagulation sampling, what you have to do is that you have a 3-way connector, which is very short dead space, not a very large regular 3-way connector. Okay. So they have these short dead space 3-way connectors. So on one side, you just draw the waste, which you are going to push back later after your sampling. So this is called closed sampling system. So this is the other alternative answer if you don't want to waste the sample. So this is just one example of that arterial sampling bundle. So there are several meta-analyses which has been done about the PBM guidelines and how it has been implemented in various aspects of PBM. And one of the main aspects of PBM is to prevent anemia. And one sub-aspect of that is preventing diagnostic blood loss, which largely contributes to hospital-acquired anemia. And so collecting small sample volume tubes, closed blood sampling device, which I just showed you some picture, point of care testing, bundled interventions, and education. So these are the means used to reduce So I'm sorry, this might not be visible. Just look at the heading. Reducing volume. Reducing volume is able to reduce hospital-acquired anemia a little bit in some of the studies, but not in all. Reducing hemoglobin and reducing transfusion. See, the reducing transfusion is a complicated outcome. So majority of the studies did not show any reduction in transfusion after implementing their interventions. So this is multifactorial. I'm not getting to go into that. But one intervention we can definitely do as a laboratory. Some of us are laboratorians. Those who are not, they have laboratorian colleagues. So what you can do, you can request your laboratorian colleagues to use smaller sample cups. So the cup in which your actual sample will be going in, I have here in the cartoon shown red, but actually what goes in is the serum or plasma usually. So it will not be red. But because it is representing blood, so I have shown it as red. So you actually have pediatric cups available. Even in India, it's available for immunoassays. But the regular biochemistry one does not have pediatric cup. But they can always take from their immunoassay counterpart. And also these cups are not there in the market because there is no demand for it. That proves how insensitive we are to our patients. We are willing to let our patients die, but we are not willing to spend money on another accessory which is available in the rest of the world. So this pediatric tube is rarely used in whole of India, but it could save a lot of patients. So these pediatric cups, these are called Hitachi cups. So these Hitachi cups are used in every clinical chemistry lab. And what is used in every clinical chemistry lab is this big one, which is like 2 ml. And this small one is like 0.5 ml. And actually what is required at the bottom, we only need, at least the machine that we have in our institute, it's a Beckman Coulter machine. Its dead space required at the bottom is 50 microliters only. Means the probe can go all the way and suck the sample up, aspirate the sample, as long as there is only 50 microliter at the bottom. But if the 50 microliter is there in the shallow cup, it might hit the bottom. And so they will not go all the way down. It might give an error. But if you use a pediatric cup, then if even 50 microliter has sufficient depth, and so the probe will not touch the bottom. And so just by using these small things, like using push-pull technique or using these kind of sampling cups, these are very cheap. These are in like not even rupees. These are very cheap things, but they're not available in India because there is no demand. So I request all of you, urge all of you to start using these kind of small things which are already there commercially. Pediatric sampling tubes, they're not vacuum, but they're pediatric. So all these small things are already there. It's there in the market, but I request you to start using them and start creating demands for them so that their price also goes down. Their price is high because they're not used. And they're not used, that's why the patients are dying in more numbers. So this is the one in dark, interdisciplinary. Blood conservation is the point I'm talking about. So PBM will be covered in a lot more detail in these 2 days. So today what I'm covering, this one. Yes, I'm finishing. Thank you. So the point where you can stop this is at the time of entry. The order should be done properly so that there is no reordering. And so there are ordering frequencies. And so if you can put a resident to follow this up, then you can get a good result. So there is one study which was done. So residents can actually, even in our institute, residents have made a lot of change to this institute. And we're thankful to our residents. And so actually the stubbornness of a resident in following the orders can make a lot of difference to the life of your patients. And so this is where I stop. This is one of the oil paintings I did as a child, as like in 8th grade, and I learned that if you use less amount of paint, you might be able to paint better. And so this is where I stop, and I take your question. Okay.
Dr. Lou Markota, Professor Department of
Sorry?
He will present the addition and management of our
loaded me. In drive me.
A very good noon. Thank you, chairpersons. Thank you, all the faculties and all the participants over here. First of all, I would like to thank the organizers for inviting me for this session, which is related to prevention and management of iron deficiency anemia. So I would like to put forth the community perspective of iron deficiency anemia, how we are trying to handle it or prevent it in the community and what challenges we are facing in that regard. So basic things which has already been covered, I'm not going to repeat all those things. Like it's a major public health problem, as we all know. It varies according to different physiological conditions, some pathological conditions, according to age, sex, smoking status, or pregnancy status. But if you look at the data, the most common cause of iron deficiency anemia, most common cause of anemia globally is because of iron deficiency, which contribute almost 30 to 60% of total anemia. Globally, I'm talking about. And according to the recent survey, or if you believe the recent data from WHO, almost 30% of the global population is affected with iron deficiency anemia. This is a global figure. But if we talk about India, these numbers are quite high in all the age groups except adults and boys. In all the age groups, this is a recent survey, NFHS 5, which was conducted in 19 to 21. And this says that more than 50% of the Indian population is still deficient in hemoglobin or iron, is suffering with anemia, except adults and boys, which has prevalence 31%. So situation is still alarming, even though government has put a lot of efforts in this direction. Most common causes of anemia that has already been discussed, so we are not going into detail of that. But again, I would say iron deficiency is the most common, and some basic symptoms by which patient present to the health facilities, to PSCs or to CSCs with weakness, dizziness, headache, or pale skin or glossitis. This is just severity of anemia classification. One thing I would like to highlight over here in the severity part is you should remember this 7 gram per deciliter for pregnant women as the important cutoff, because we will be discussing this in subsequent slides. So if hemoglobin is less than 7, it should always be considered as severe anemia and should be treated accordingly. Now coming to the major part of this presentation, that is preventive aspect, what government is doing and how what type of challenges we are facing in managing those anemic patients or preventing the anemia. So first program which was launched by government is National Nutrition Anemia Prophylaxis Program. It was dealing with the prophylactic part basically. Later on, the names were changed with time, and government took many efforts. Recently, if we talk about its Anemia Mukt Bharat, it was nationwide initiative, intensified initiative. So this prophylaxis against nutrition anemia was started in 1970. It was a centrally sponsored program with few objectives. Major objective was to screen the anemia, to find the exact prevalence of anemia, because that was the time when exact data was even not available. So this was one of the major objective of this program, and treatment was a secondary part, though Iefa supplementation was a priority, and the age group was very much limited to pregnant women, to lactating mothers, and to minor children, that is 5-year to 12-year age group. So these were the only age groups which were targeted during that program, when this program was started. But unfortunately, the program couldn't roll back properly, and it was a failure program. Later on, in 1991, the program was renamed as National Nutrition Anemia Control Program. The government priorities shifted from prophylaxis to control somehow. Later on, a few more things were added. And recently, 2013, where it was launched as National Iron Plus Initiative Program. Iron Plus Initiative is nothing but to increase the horizon of age coverage. So it covers almost all the ages. If you can see this diagram, it starts from 6 months. The moment exclusive breastfeeding overs, the iron supplementation starts. So it starts from 6 months, though there are different age groups in 6 to 60 months or up to 5 years. There's a bi-weekly supplementation. Special syrup bottles have been designed for that with special dispenser. Then adolescent, which is covering 10 to 19 year of age group. It's a weekly supplementation. Children of 5 to 10 year, again, it's a weekly supplementation. Then reproductive age group female, which covers 15 to 49 year of age, 25 to 49 year of age group females, and pregnant and lactating women, as it was going on previously. So it's a bi-weekly supplementation for 6 months to 59 months. Please give a focus on the dose and kind of tablets which has been distributed by government to tackle this problem in community. So the syrup has been designed for 6 to 59 months. It should be given bi-weekly, and 1 ml of iron and folic acid syrup, which has 20 milligram of elemental iron and 100 microgram of folic acid, 1 ml, and it should be given bi-weekly. For 5 to 9 years, these are called junior tablets. They are again of red color tablets, and these tablets should be given on weekly basis. 1 iron tablet contains 45 milligram of elemental iron and 400 microgram of folic acid. Then comes adolescent girls. A special color tablet has been designed for adolescent girls and boys. Now boys have also been covered, though the prevalence is very low, it's 31%. So special blue color tablets have been designed by Government of India under a campaign that is called WIFS campaign, Weekly Iron Folic Acid Supplementation campaign. Then for women of reproductive age group, it's a weekly supplementation, one iron tablet which has 60 milligram of elemental iron. I want to make a statement over here that initially when the program was started, the tablet was of 60 milligram elemental iron. In some middle part, some almost 10 years, it was 100 milligram elemental iron. And it was observed based on some studies that it is causing it is reducing the compliance to iron folic acid supplementation among the community because of this gastritis symptoms. So ultimately government in 2019 has changed the guidelines again. 2020 it was launched, and now it is 60 milligram elemental iron. Though the old supply might be continued with 100 milligram, but now the guideline is 60 milligram of elemental iron. Should be given weekly if a woman is in reproductive age group. And so total 52 weeks are there in a year, so 52 tablets should be delivered. Pregnant and lactating women, it's for 180 days during pregnancy, 180 days postpartum during lactation with the same schedule. Along with that, deworming is also prescribed. So for children, if it is 12 to 59 months of age, biannual deworming is recommended with 400 milligram of albendazole. That is half tablet if less than 2 years, and 1 tablet if is more than 2 years. 5 to 9 years is biannual dose of again 400 milligram albendazole. Same for school going adolescents, for pregnant of reproductive age group women. But for pregnant women, only 1 dose is sufficient. That is 400 milligram of albendazole, preferably should be given during second trimester of pregnancy. So these are the guidelines under National Iron Plus Initiative by Government of India. Now coming to the WIFS, which is very important. Weekly iron folic acid supplementation, it's called WIFS Blue campaign, a special color tablet, blue color tablet. Now, try to understand, this program has been designed by Ministry of Health and Family Welfare. The tablets are supplied by Ministry of Health and Family Welfare. Now, who will distribute the tablets? If I talk about the adolescents who are going into the school, so school teachers will play a role in distributing the tablets. So Ministry of Education is involved. If kids are out of the school or not going to school, then Anganwadis are giving those tablets. So Ministry of Women and Child Development is involved. So it's the best example of an interministerial coordination. 3 different ministries are coming together to deliver Iefa supplementation to adolescents in our country. So this is about weekly iron folic acid supplementation. Another strategy which was opted by Government of India is Anemia Mukt Bharat. Recent one, you might have heard about it a lot. Intense, it was nothing, age groups were same, but it was a kind of intensified program which was launched by Government of India to reduce the burden of anemia, to reduce it by 3% every year rather than 1%. Our reduction rate of anemia prevalence was very slow. So that's why government started this in a campaign mode. It was proposed with a 6 by 6 by 6 strategy. 6 beneficiaries, which we already discussed, starting from 6 months to almost all the age groups. Then 6 interventions and 6 institutional mechanisms. Most important intervention is again same, which started with 1970, prophylaxis of iron folic acid supplementation. It was along with the deworming, then intensified behavior change communication, then testing. Yes, one more thing which was introduced during this Anemia Mukt Bharat is a digital testing of hemoglobin. So testing, it was based on many studies which has proved that HemoQs have higher accuracy, higher sensitivity, and higher specificity as compared to Sahli's method of hemoglobin estimation, because there are subjectivity involved in that. So it was recommended to test the hemoglobin on spot with the digital HemoQs to treat it and to trace the anemia into the community. So trace, test, and treat was the strategy in this Anemia Mukt Bharat program. Then mandatory provisions of IFA fortified foods, and there are other interventions also. So 6 interventions, 6 institutional mechanisms, 6 beneficiaries. Though we are not going into theory part of this, the important institutional mechanism which I would like to highlight here is this interministerial coordination, because that is very important. Because anemia is a disease which doesn't persist in isolation. It's a multifactorial disease. And if you want to really control it or really reduce it, you'll have to bring all the ministries or many ministries into the same platform. So that was the institutional mechanism which was proposed by government. Now there are certain challenges in Ifa supplementation. As I told, most common side effect is, you can say, nausea or gastritis or nauseatic feeling or vomiting. This is the only side effect which is leading to very poor compliance of Ifa tablets into the community. I've seen in my career many examples, n number of examples. If you give 100 tablets to a pregnant female, she'll consume hardly 5 or 6 tablets and she'll throw all the tablets. So that is, NFHS also says the same thing. 77.7% of pregnant females, they are receiving IFA, but only 33% are consuming. That is a national figure. I'm talking about few of experiences, decentralized experiences of mine. A simple solution to this is, like, if it causes gastritis, if it causes nauseatic feeling, the simple solution is it should be taken at the night before going to bed. That is the very simple solution which we as a practitioner might forget while we prescribe the Ifa tablet to pregnant female. The very simple 1 or 2 counseling points which should always be added. That's why this behavior change communication is also an important institutional, important strategy, intervention strategy for this Anemia Mukt Bharat. So that counseling part is missing practically. If I talk about practically in PSCs, in CSCs or health facilities, we prescribe, but we just forget to tell or we overlook these 2-3 important counseling points. कि रात को चाय नहीं पीना है, कैल्शियम के साथ नहीं खाना है, रात को सोने से पहले ले लो अगर nausea आता है तो. So these are simple things which can change the whole picture. Second thing which we already discussed, in government supply, 60 milligram, the guidelines has been changed, but still 100 milligram elemental iron tablets are still in government supply. And as I told, there are many studies which has proved that these causes increased risk of gastritis and gestational diabetes mellitus, and ultimately to poor compliance. Another strategy which is very important is iron sucrose injection. So it's an intravenous method to rapidly correct hemoglobin and iron store. So it's better tolerated than iron because you are correcting it very fast in a week or in a 2 week. You will correct all the iron, you replenish all the iron stores. Most common formula which is used in our facilities is iron sucrose, though there are other formulations available for most common supplies of iron sucrose. There are certain indications. First indication is it's a moderate anemia in pregnancy during postpartum period if oral iron is not tolerated. If any case, if oral iron is not tolerated, this is the best option. But in case of moderate anemia, second thing is if female comes with after 34 weeks of pregnancy, you don't have time to correct the anemia with iron folic acid supplementation. So better to go with the iron sucrose injection or iron sucrose infusion. If there is no improvement in hemoglobin, even after or less than 1 gram per deciliter improvement after 1 month of oral IFA, that means female is not responding to IFA. So in that case also iron sucrose is indicated. Another indication is postpartum. Just after the delivery, because hemorrhage is a most common cause of maternal mortality in our country. Hemorrhage, anemia, and sepsis, these are 3 most important causes. So just after the postpartum, just after the delivery, because of that hemorrhage, hemoglobin goes down, and at that time, it is recommended to give iron sucrose if there is even moderate anemia, not severe anemia. Now, at the same time, there are certain contraindications also which you should always consider in your mind. Patient sorry, if patient have iron overload, if anemia is because of some other reason, if there is a hypersensitivity to patient because of iron, if there is a liver disorder, if there are cardiac disorders, so those kind of things should be inquired. If there are certain sort of hemoglobinopathies, so those things should be inquired before prescribing or before giving iron sucrose. So be cautious while prescribing. Now, if we talk about the administration part, it should always be given not very slow, not very fast. The ideal time is 30 minutes. So one infusion should take at least 30 minutes. It should not be given very fast. It will create side effects. It should not also be given at the same time very slow. The dose is 200 milligram per dose in 100 ml of normal saline. This is the maximum dose you can give in one shot. So 200 milligram. You can give 100 milligram also, but 200 milligram is the maximum dose you can give in one shot. And should be given over 20 to 30 minutes. Maximum dose, again, which is very important point, which can be given in 1 week is 600 milligrams. So not more than 3 shots in a week of 200 milligram. It should be given alternate days. So that is the way to give iron, to supplement the iron to a person who is deficient in iron. And one more important thing which is commonly deficient in our facilities is it should be under supervision. So this 20 and 30 minutes should be completely under the supervision of preferably medical officer, if not at least nursing officer. And one more important thing, monitoring of vitals. So the vitals should be monitored 5 minutes before and at the end of infusion. Now the question is how to maintain this 30-minute duration. So the way we usually recommend is in initial 5 minutes, you make it 25 to 30 drops per hour, that's speed, and per minute. And then you change it to 60 to 70 drops per minute after 5 minutes. You check the vitals, if everything is okay, increase the dose to 60 to 70 drops per minute. So automatically it will be finished in 30 minutes. Certain precautions which should always be kept and which should always be considered. Universal precautions are always there whenever you are giving any infusion. These are general precautions only. Life-saving equipment should also be there. Avil-Dexona and everything. Hand hygiene should be properly followed. Discarding of remaining drug, that is also very important. I have seen many cases where the drug bottles are still there when a patient has gone and they are not discarding it properly. At the end, when new patient comes, they are just looping it around and throwing it into dustbin. So these kind of things should also be changed. Now, one important thing which also I would like to highlight is dose calculation. How much dose should be given to let's say, for example, for pregnant female. So there is a very simple formula. This is another challenge actually in community settings where we are not calculating the exact dose. We are giving iron sucrose, but randomly. So this Ganzoni's formula says that total iron deficit in milligram should be equal to body weight of that lady. Body weight, it should be pre-pregnancy body weight. If that is available, if that is not available, you can take the first trimester, first visit body weight. So body weight, pre-pregnancy body weight into target hemoglobin. For example, if I'm talking about pregnant lady, the target hemoglobin is 11 gram per deciliter. 11 minus actual hemoglobin into 2.4 plus 500. 500 is to replenish the stores. For example, I've taken one example over here. If a pregnant female has a weight of 60 kg, that is pre-pregnant weight, and hemoglobin level of 9.5. If I put it into the formula, so 60 into 11 minus 9.5 into 2.4 plus 500, that is 716 milligram. Now you know the exact dose, how much it should be given, 760 milligram. Now remember those important points. In one shot, you can give maximum 200 milligram. And you will have to replenish 716 milligrams. So 4 doses at least, 200 milligram. So alternate days in a week, maximum 600 milligram, and in next week, one more dose of 200 milligram. If it comes to 700, you reduce the dose to half. 700 means 200, 200, 200, and in the next week, you give only 100. So use only one ampule. Yes. Regarding those ampules of iron sucrose, there are 2 types of ampules which are in government supply. One is 2.5 ml ampule, one is 5 ml ampule. 5 ml of ampule have 100 milligram of elemental iron. So if you make it 200 milligram, 200 per dose, then put 2 ampules of 500 milligram into the solution, 100 ml normal. If you want to make it 100, then put only 1 ampule of that. So this is another important point which I wanted to highlight because this is another challenge. And follow up after 4 to 6 weeks, after 1 month, again you should check whether how much was the hemoglobin improvement, and ideally based on the recommendation it should be almost 2.5 gram per deciliter in case of severe anemia and 1.6 gram per deciliter in case of moderate anemia. One more thing, if hemoglobin is less than 5 milligram per deciliter in pregnant female, always go with blood transfusion. Don't try iron sucrose. So it should be with severe anemia, but the cutoff is 5 to 7 milligram of hemoglobin. If it is less than 5, go with the blood transfusion and preferably packed RBCs, not with the whole blood, because pregnancy is a state of hemodilution. There are certain challenges. Testing is not being done still by digital methods. That is one of the limitations. So there are subjectivities involved. So exact dose calculation depends on your exact hemoglobin estimation. So hemoglobin estimation agar wrong hai, to dose calculation will vary. Proper guidelines are not followed of injection, as I told, 200 milligram and 600 milligram per week. Dose properly not calculated. No one to monitor for 20-30 minutes. I have seen cases where nobody is there to monitor. I'll show you some pictures also I might have bought. And equipments also not properly maintained. Sometimes remaining drugs are not discarded properly. These are some of the pictures from one of our centers. So where the monitoring has not been done, patient is on iron sucrose injection and nobody is there to monitor. Some infrastructure issues, some behavioral issues, these kind of issues are always there in facilities. But just by simple interventions, we can change those things. Another thing which is an important strategy in Anemia Mukt Bharat is this compliance part, which we already discussed, IYCF, infant and young child feeding. So adequate complementary feeding should also be practiced starting from the childhood. The child should not undergo into anemia. Increase iron rich or protein rich or vitamin C rich food. We are not going into detail of those things because these are theoretical parts mostly. And promote practice of delayed cord clamping. That is also very important. At least 3 minutes of delay should be promoted because it gives additional blood to child at the time of birth. So these are some of the references which I've used during the presentation. It's all about from my side. If you have any question, any comment, any suggestion.
I kindly request our chairperson, Dr. Manju Vora ma'am, to felicitate our speaker. I also request Dr. Manju Vora ma'am to felicitate Dr. Saptarishi Mandal.
Now, I would like to invite Dr. Amit Sharma, Professor in the Head Department of Transfusion Medicine, Dr. Sharma will deliver a lecture on evidence-based blood transfusion.
Good afternoon, Dr. Devraj, Madam Manju, Madam Archana ji, my colleagues. Evidence-based blood component therapy. Before starting, I just want to few questions to my clinicians. How many clinicians are there? Can they raise their hands? Yes. So, few of my queries. you have to before taking decision of transfusion, how many times you think that this transfusion is judicious, and how much you give importance to the clinical picture and relevant investigations, because most of my requisition forms comes into the blood transfusion department. Neither the value of hemoglobin is mentioned, nor the counts of the platelets, nothing, no coagulation factor deficiency, except demand. So no relevant investigation, no short clinical history. So my request, always you go through the clinical picture of the patient and relevant investigation before demanding any blood or blood components. Second, whatever blood component you need, you must write down which component, the amount of the component, the time when you need it, and the quality of that. It is very important. Third, during the round, when you are taking the decision of the transfusion, आप लोगों का क्या सिस्टम रहता है कि आप जो ट्रांसफ्यूजन की डिमांड कर रहे हैं उसका इंस्ट्रक्शन या डॉक्यूमेंटेशन बेड हेड टिकट्स के अंदर होता है? यस और नो? मोस्ट ऑफ द टाइम द बेड हेड टिकट्स जो हैं उस पर डॉक्यूमेंटेशन ही नहीं है कि हाउ मच अमाउंट ऑफ दैट यूनिट इज रिक्वायर्ड और विच प्रोडक्ट इज रिक्वायर्ड. देन after giving instruction for blood transfusion, how your staff know who is the recipient? Patient identification आप किस तरह से करते हैं? क्योंकि आप तो इंस्ट्रक्शन देके चले गए अपने रेजिडेंट्स को या सबऑर्डिनेट स्टाफ को, आपका नर्सिंग स्टाफ उस रेसिपिएंट को कैसे आइडेंटिफाई करता है? Second, what is the correct methods to collect the samples for blood transfusion? Who is doing the phlebotomy or sample collecting? Who is the responsible for that? Then, how you are sending the samples to the blood bank? Have you ever explained the importance of the transfusion? Have you ever taken the written informed consent? No. How you are getting the blood, and what are the circumstances in which you can say, no, I will not take this product, or this product is not suitable for my patient? How to maintain different products in your ward? Suppose you are demanding PEG cells, FFP, and platelets. How you are maintaining all these products at different temperatures? ये सब क्वेश्चन मैं आपसे इसलिए पूछ रहा हूँ कि अगर आपने अपने सबऑर्डिनेट स्टाफ, नर्सिंग स्टाफ, टेक्निकल स्टाफ, अपने वार्ड के स्टाफ को अगर ये सब चीजें एक्सप्लेन नहीं कर रही है तो हमारा ट्रांसफ्यूजन मेडिसिन का कोई रोल नहीं रहता. क्योंकि सपोज अगर हमने आपको प्लेटलेट सप्लाई करी है और दैट प्लेटलेट्स आर ट्रांसफ्यूजिंग आफ्टर 8 hours or 10 hours or नेक्स्ट डे, तो देयर इज नो यूज. कुछ और क्वेश्चंस भी हैं, प्लीज आई विल टेक एक्स्ट्रा 5 minutes. जस्ट आई वांट टू नो, अगर ट्रांसफ्यूजन रिएक्शंस होती हैं, हाउ यू आर मैनेजिंग इट एट योर वार्ड, एंड व्हाट वी एक्सपेक्ट फ्रॉम यू, एंड हाउ यू आर sending the samples, fresh blood samples, urine samples, bag and other things. Do you know the correct way of that? And what is the responsibility of blood transfusion department if they got this any information about the adverse transfusion reactions? The role of transfusion faculties after the reaction. How to send fresh sample of blood, urine and other things to properly to the blood bank. And documentation. आप लोग प्रॉपर डॉक्यूमेंटेशन करते हैं या नहीं करते हैं? Although this CME डॉक्टर अर्चना बहुत इसको इंटरेस्ट लेके बहुत हार्ड वर्क करके इन सब क्वेश्चंस के आंसर आपको देंगी, but unless until if there is a communication gap between the physicians and clinicians and the faculty of transfusion medicine, हम अपना टारगेट अचीव नहीं कर पाएंगे. So just I will start the evidence-based blood component therapy. All blood products, the main blood components are packed red blood cells, PRBC, random donor platelets, RDP, fresh frozen plasma, FFP, cryoprecipitate, cryopoor plasma, or CPP. The apheresis components are apheresis platelets, apheresis plasma, red blood cells, white blood cells, that is granulocytes. It is of mononuclear cells or hematopoietic progenitor cells, plasma and recombinant products like albumin, immunoglobulins, including immunoglobulin replacement therapy, and hyperimmunoglobulins and clotting factors. Standard blood components are whole blood, packed red cells, platelets, RDP, SDP, FFP, cryoprecipitate, and specialized are saline washed red cells, frozen red cells, leukodepleted components, and irradiated components. Case study. A patient comes into the hospital, their hemoglobin level are tested on the day of their surgery are 7 gram. They undergo hip surgery, transfusion. The patient required transfusion of 2 bags of blood during surgery. The units documented in the patient's clinical record by the theater nurse. Adverse event, immediately after surgery, the patient exhibited sign of transfusion-associated circulatory overload. Outcome, the patient recovers. The patient complains to the hospital that they didn't want a transfusion, and the hospital did not provide them with information about addressing the issue of the anemia and methods to minimize blood transfusion. Assessment of process. Step 1. Does the hospital offer pre-surgery full blood count testing? Should the surgery have proceeded in the presence of undiagnosed anemia? Was the patient provided with information and did they have informed consent? जो क्वेश्चंस मैंने आपसे इनिशियली पूछे थे वही क्वेश्चंस यहाँ आपसे वापस पूछे जा रहे हैं. मैं सभी फिजिशियंस और क्लिनिशियंस से पूछना चाहूंगा कि क्या वो इस चीज को फॉलो करते हैं, यस और नो. It is very, very, very important to follow these instructions. Assessment process step 2. They require a transfusion of 2 bags of blood during surgery. The units are documented in the patient's clinical record. Were all relevant details documented in the patient's clinical record? Were 2 bags required, or could they have used only 1? Or none? Was proper patient and product identification undertaken to ensure they got the correct unit of the red cell concentrates? Assessment of process step 3. Immediately after surgery, the patient exhibited sign of transfusion-associated circulatory overload. Was this adverse event reported? मोस्ट ऑफ द टाइम मैं आपको सही बता रहा हूं कि हमारे यहाँ किस तरह से ट्रांसफ्यूजन रिएक्शन आती है. किस तरह ट्रांसफ्यूजन रिएक्शन हुई, कब हुई? सर 2 दिन पहले. 2 दिन पहले की रिपोर्ट आप अगर 48 आवर्स बाद कर रहे हो, क्या मतलब है इसका? नो सेंस. Was the response to the adverse event appropriate? Was a root cause analysis undertaken? कभी हम सोचते ही हैं. Assessment of process step 4. The patient complains to the hospital that they didn't want a transfusion and the hospital did not provide them with information about addressing the issue of the anemia and methods to minimize blood transfusion. Was the patient and the health service organization exposed to unnecessary risk? What are the actions that could be undertaken to reduce future risk? हम लोग आपस में बैठ के कभी बात करते हैं. हॉस्पिटल ट्रांसफ्यूजन कमेटी का जो रोल है, दैट इज इम्पोर्टेंट पार्ट, वो भी हमारे यहाँ प्रॉपरली नहीं हो पाता. So now come to the 6 essential elements of safe transfusion. This is very important slide. Blood and blood products are used and managed in accordance with national evidence-based guidelines. It should be totally accordance with national evidence-based guidelines. A program is in place to reduce the risk associated with blood and blood product and to improve safety and quality. देखिए, आपको बताऊं कि नेचर बहुत होशियार है, हम उसके सामने कुछ नहीं है. Nature has given red color to the blood and red is a sign of danger. So blood transfusion is always double-edged sword. एक तरफ ये लाइफ बचाती है तो सेकेंडली दूसरी तरफ there are many complications of transfusion. Adverse events, incidents, and near misses relating to the transfusion practice are reported and feed into risk management process. Transfusion details are documented in patient's clinical record. Most of the time transfusion जब होता है, हम कई बार समझाते हैं कि how to monitor the transfusion. कब वाइटल्स लेने हैं, क्या क्या चीज मॉनिटर करनी है, कितने कितने टाइम में करनी है, बिफोर ट्रांसफ्यूजन, एट स्टार्ट ऑफ ट्रांसफ्यूजन, अप टू 15 मिनट्स, एवरी आवर, आफ्टर कंप्लीशन. सो एवरीथिंग शुड बी वेल डॉक्यूमेंटेड. Blood and blood products are managed appropriately. Informed consent is documented for transfusion. आजकल लीगल प्रॉब्लम्स बहुत होने लग गई. Red cells. Routine use of whole blood is not advised. जहां components की facilities available है, components are available है, please avoid use of whole blood. Red cells main use in anemia, mainly hematology और oncological patient. जो अभी न्यूट्रिशनल एनीमिया की बात हुई है, जो और कई तरह के एनीमियाज हैं, वहां प्लीज अवॉइड ब्लड ट्रांसफ्यूजन. अगर हेमेटोलॉजी, अगर बोन मैरो फेलियर है, एप्लास्टिक एनीमिया है, कोई और कॉज है, वहां आप इसको यूज करें. ट्रॉमा, एक्सीडेंटल इमरजेंसीज, सर्जरी and time taken for issue, ABO compatible blood without cross match can be available 15 minutes after acceptance of the suitable sample, and if complete cross matching, it will take 45 minutes to hour. RBCs are stored in refrigerator at 2 to 6 degrees centigrade. Hemoglobin level and symptoms. If the hemoglobin levels between 9 to 11, they are very minimal symptoms, only fatigue and weakness. But when the hemoglobin level is less than 7.5, there is exertional dyspnea. If it is less than 6, weakness. If it is less than 6 or around 4, it is orthopnea or dyspnea at rest. And if the hemoglobin level is below 3, chances of heart failure. RBC transfusion indications. If the patient is anemic and hemodynamically stable, if patient anemic है but हेमोडायनेमिकली स्टेबल है, हीमोग्लोबिन इज मोर देन 9, उसको कोई प्रॉब्लम नहीं है, प्लीज डू नॉट ट्रांसफ्यूज। इफ हीमोग्लोबिन इज मोर देन 9 बट अगर उसके साथ कुछ मॉर्बिडिटी, कोमॉर्बिडिटी है, सपोज सीवियर सेप्सिस है, न्यूरोक्रिटिकल केयर चाहिए उसको, इस्केमिक हार्ट डिजीज है, उसको कुछ और प्रॉब्लम है, then only then you need transfusion. Otherwise, there is no need of transfusion at hemoglobin level if it is more than 9. This is already डॉक्टर भाटिया ने और डॉक्टर साहब ने पहले भी क्लियर कर दिया है। हीमोग्लोबिन अगर लेस देन 7 ग्राम है तब हम स्ट्रांगली वो करेंगे। अगर आईसीयू पेशेंट है वहां 7 ग्राम से कम है, या पोस्ट ऑपरेटिव ऑर्थोपेडिक और कार्डियक सर्जरी है जहां हीमोग्लोबिन लेवल 8 ग्राम से कम है, वहां हम स्ट्रांगली रिकमेंड करते हैं। ओवरऑल इज प्लीज वी हैव टू अवॉइड ट्रांसफ्यूजन अनलेस अंटिल इट इज रियली रिक्वायर्ड। आपको क्लिनिकल पिक्चर देखनी है, उसकी हीमोडायनेमिक्स देखने हैं, आपको सब चीज बैलेंस करके एंड देन ही आपको डिसीजन लेना है। प्रिंसिपल ऑफ क्लिनिकल ट्रांसफ्यूजन प्रैक्टिस। Transfusion is only one part of patient management. Everything depends on transfusion, या transfusion ही सब कुछ ठीक कर देगा ऐसा नहीं। It is only one part. Prescribing should be based on national or international guidelines. Blood loss should be minimized to reduce the patient need for transfusion. The patient with acute blood loss should receive effective resuscitation while the need for transfusion is being assessed. क्योंकि जैसी एक्सीडेंटल इमरजेंसी, ट्रॉमा या कुछ ऐसे कंडीशन में पेशेंट आता है उसको असेस करने में टाइम लगता है। ट्रांसफ्यूजन के लिए ब्लड आपका जब तक ब्लड मैनेजमेंट होता है उसमें टाइम लगता है, उसके पहले आपको दूसरी चीजें हैं ना आपको लाइन में लेनी है। अगर क्रिस्टलाइड फ्लूइड्स हैं, कॉलॉइड फ्लूइड्स हैं, अदर आईवी फ्लूइड्स हैं, आप उनके ऊपर बेटर कंसंट्रेट करें rather than depends on transfusion. The patient hemoglobin value should not be the sole deciding factor in starting transfusion. Should be based on clinical signs and symptoms and prevent significant morbidity and mortality, because transfusion is associated with morbidity as well as mortality. Transfusion should be prescribed only when the benefits to the patients are likely to outweigh the risk. Reason for appropriate use: economy, scarcity of the resources. Out of 4, only 1 person is getting blood components. Safety, inherent risk involved in the transfusion therapy. 1 in 2 million get HIV. TTI जो है, window period है, एक ऐसी चीज है जिसको कोई नहीं रोक सकता। So there are chances. Scientifically appropriate hematinics can be used in nutritional anemia. 1 unit can save 3 to 4 lives. अगर आप होल ब्लड से कंपोनेंट प्रिपरेशन करते हैं, आप रेड ब्लड सेल्स बनाते हैं, एफएफपी बनाते हैं, कंसंट्रेट, प्लेटलेट कंसंट्रेट एंड क्रायोप्रेसिपिटेट, और इनका आप 1 यूनिट से 4 कंपोनेंट बना के 4 डिफरेंट पेशेंट्स को डिफरेंट यूज के लिए ले सकते हैं। होल ब्लड सेल्फ लाइफ 35 days, hematocrit around 35 to 40%. Each unit increase hematocrit by 3 to 5% or hemoglobin by 1 gram per deciliter. Uses exchange transfusion. Nowadays, reconstitution of blood. That means the packed cells of O negative blood and plasma of AB positive blood, उनको रिकंस्टिट्यूट करके एक्सचेंज ट्रांसफ्यूजन के अंदर बच्चों में, न्यूनेट के अंदर यूज किया जा रहा है। इट इज बेटर टू यूज रिकंस्टिट्यूशन ऑफ ब्लड इन एक्सचेंज ट्रांसफ्यूजन इन न्यूनेट्स। और होल ब्लड का एक यूज और है, एक्टिवली ब्लीडिंग पेशेंट विद ब्लड लॉस मोर देन 30% ऑफ ब्लड वॉल्यूम। Fresh blood, a misconception. What is fresh? Unit capped at 4 degrees centigrade. 4 hours is no longer fresh. Storage lesion in different constitutes due to storage temperature. Increased risk of disease transmission. Fresh blood में disease के transmission की ज़्यादा chances हैं. Intracellular pathogens, cytomegalovirus, STLV virus survive in the leukocyte in the fresh blood. Syphilis transmission, trypanosoma cannot survive more than 96 hours in stored blood. Why whole blood is not rational? Because plasma citrate levels, allergic reaction, FNSTR, risk of TTI, and waste of components are more than if you go through the packed red cells. Packed RBCs, component of choice to maintain adequate supply of oxygen. Hematocrit is 65 to 75, volume 250 to 300 ml. A unit of RBC will increase hematocrit by 3 to 5% and hemoglobin by 1 gram per deciliter. Indications, symptomatic anemia where the hemoglobin is less than 7 or 8 gram. Acute blood loss, pre-operative hemoglobin less than 7 gram. Chronic transfusion patient like thalassemia patient or hemophilic patients. Storage 2 to 6 degrees centigrade. Administration ABO and RS compatible, 1 to 2 ml per minute in first 15 minutes, then as approximately 4 ml per minute after first 15 minutes. Never add any medications to a unit. Most of the times, nursing staff जिस ट्यूब से आप ट्रांसफ्यूज कर रहे हैं उसी कैनुला से वो दूसरी मेडिसिन ट्रांसफ्यूज कर देते हैं. Never add any medication in that set. The complete transfusion within 4 hours of the commencement. अगर पेशेंट कार्डियक फेलियर में है या कुछ इंसिपिएंट कार्डियक उसको प्रॉब्लम्स हैं वहां आप स्लो ट्रांसफ्यूजन करेंगे और अंडर use of the diuretics. Leuko-reduced RBCs prepared by removing a proportion of the plasma from leukocyte depleted whole blood. Non-leuko-reduced RBC contain 1 to 3 into 10⁹ WBCs and leuko-reduced contain less than 5 into 10⁶ WBCs. By leukoreduction, chances of febrile reaction can be reduced. Indications are chronically transfused patients, especially thalassemic patients, potential and transplant recipient, patient with previous febrile non-hemolytic transfusion reactions, cytomegalovirus seronegative at risk, patients for whom seronegative components are not available. Leukoreduction at time of preparation is better than if you are using filters at time of transfusion. Administration must be ABO and RHD compatible with the recipient. A leukocyte filter may also be used at the time of transfusion if leukocyte depleted red cells or whole blood are not available. Irradiated blood. Gamma irradiation, cesium or cobalt, dose is 25 GY, prevents transfusion-associated graft versus host disease, and blood must be labeled irradiated. Indications, bone marrow transplant, congenital immunodeficiency, premature infants, intrauterine transfusion, and first-degree relatives. Side effects and hazards of irradiation. Irradiation induces erythrocyte membrane damage. Irradiated red cells have been shown to have higher supernatant potassium level than non-irradiated red cells. Removal of residual supernatant plasma before transfusion may reduce the risk associated with elevated plasma potassium. Hyperkalemia cause cardiac arrhythmia और इन neonates में और बच्चों में हमको अवॉइड करना बहुत जरूरी है. अगर पोटेशियम लेवल ज्यादा हुआ और बच्चों में कार्डियक अरिथमिया हो गया तो मोस्ट ऑफ द टाइम डेथ होने की चांसेस बढ़ जाते हैं. The expiry date of irradiated red cell is 28 days after irradiation or expiry of the blood product or whichever is earlier. Vast red cells. Saline washing of the red cell result in removal of the leukocytes and platelets. Washed components are typically prepared using 0.9% sodium chloride, indicated to remove unwanted plasma that predispose patient to significant transfusion reactions. प्लाज्मा सबसे ज्यादा एंटीबॉडीज, सारी एंटीबॉडीज प्लाज्मा में होती है और प्लाज्मा सबसे ज्यादा एलर्जिक रिएक्शंस के लिए रेस्पॉन्सिबल है. There can also be some loss of red cells and platelets as well as loss of platelet function through platelet activation. Self-life of vast red cell is not more than 24 hours at 1 to 6 degrees centigrade or 4 hours at 20 to 24 degrees centigrade. Platelets. Platelets prepared from units of whole blood that have not been allowed to cool below 20 degrees centigrade. Storage. Platelets may be stored for up to 5 days at 20 to 24 degrees centigrade with gentle agitation and infused within 30 minutes. Dosage: 1 unit of platelet concentrate per 10 kg for an adult of 6 to 7 kg. Random donor units 5000 काउंट्स बढ़ते हैं, जबकि अगर अपन एसडीपी लें तो अराउंड 40 to 50,000 प्लेटलेट्स काउंट बढ़ते हैं. इंडिकेशंस: नॉन ब्लीडिंग पेशेंट्स एंड ब्लीडिंग पेशेंट. ब्लीडिंग पेशेंट है अगर काउंट्स हमको अगर 50,000 से कम है तो इंडिकेशन है. अगर न्यूरोलॉजिकल सर्जरी है तो वहां आपको मोर देन 1 लाख चाहिए. अगर आप सर्जरी कर रहे हैं तो बिटवीन 50,000 to 1 लाख प्लेटलेट काउंट चाहिए. Administration: ABO RH compatibility preferred, not required. FFP: plasma collected from single donor units or by apheresis, frozen within 8 hours of collection, consists of labile and non-labile clotting factor, albumin and immunoglobulins. Factor 8 level at least 70% of the normal fresh plasma level. Indications: in the liver disease, anticoagulant overdose, depletion of the coagulation factor in patient receiving large volume of transfusion, DIC and antithrombin deficiency, immunodeficiency syndrome. Dosage: 15 to 20 ml per kg. Administration must be ABO compatible, RS not required. Cryoprecipitate: insoluble portion of the plasma remaining after FFP has been thawed under controlled conditions. Indications: hemophilia A, von Willebrand's disease, congenital or acquired fibrinogen deficiency, factor 13 deficiency. Administration: cross-match and ABO compatibility is not required. Infusion as soon as possible after thawing within 30 minutes. Granulocyte concentrate prepared by apheresis and stored at 20 to 24 degrees centigrade. Indication: bone marrow showing myeloid hypoplasia, absolute neutropenia or neonatal septicemia unresponsive to appropriate antibiotic therapy. Mostly इसका बहुत ज्यादा यूज नहीं है. Storage of blood ये आपको सबको पता है. The main thing is for blood component, what are the goals? We have to cater to the patient need, provide blood and blood components which are safe, potent and effective, and policies and procedures so that our goals should be met. And the 5 right of transfusion: ensure that right patient is getting the right product in the right amount at the right rate at the right time. This is our goal. Thank you.
And a very common topic, a very important topic, because most of us don't know the clinician question after because most of the clinicians blood can be up to fix this problem that where to give or where to not to give, but they don't that whether it is required or not. They just ask, send the 4 blood, send 4 FFP, 6 liquid, 2 bio. In one they will take it. So there should be the proper use of this component. And it was very well explained by the Thank you.
Thank you.
Thank you, sir, for such a high-yielding session. I humbly request Dr. Devracharya, sir, to felicitate Dr. Amit Sharma, sir.
Now I request Dr. Prabodh Karthikar, Assistant Professor, Department of Orthopedics, to present his presentation on intraoperative hemorrhage management in orthopedic surgery.
Good afternoon, everyone. I am discussing how to minimize the bleeding during the surgical procedures. The title of my topic is Pillar 2, Minimizing Operative Blood Loss. Pillar 2 here refers to the second pillar of very widely used, very recent, very comprehensive approach of managing patient's blood, that is patient's blood management. This is a multimodal 360-degree comprehensive approach, which was imbibed by WHO also around 10 to 12 years back. It focuses of the management of blood from pre-operative phase till the recovery phase. Perioperative bleeding remains a major risk during and after surgery and also before the surgery, and is associated with the high rate of death, complications, and healthcare resource use. Perioperative anemia, perioperative bleeding, and red blood cell transfusion are associated with increased mortality at long-term follow-up, and all these factors are identifiable and preventable. So the 3-pillar approach of patient blood management includes detection of preoperative anemia and makes endeavor to minimize the further aggravation of this anemia during surgical procedure, and after surgical procedure, how to optimize the patient so that he or she will not require much transfusions after the surgery. So starting from the preoperative phase, the foremost thing is structured and detailed history. If the history is insignificant, means there is no history of any previous major bleeding, there is no history of any family blood diathesis, and patient is not taking any antiplatelet or anticoagulant medications, then routine coagulation testing is not mandatory, because the predictive value of these tests for bleeding is not much good. But if there is positive history of bleeding in past, there is positive family history, patient having any blood diathesis condition, then we have to quantify the risk of bleeding during the surgical procedure, for which we need to check the coagulation profile of the patient in the form of PT-INR, APTT, BTCT. And we have to discuss the case with hematology and with the blood bank department. And we have to stop anticoagulant medications at optimal point of time. And in many of the conditions, we might have to switch to a bridging anticoagulant in high-risk patients. Aspirin can be continued for most procedures. Clopidogrel, which is also an antiplatelet drug, need to be stopped 5 to 7 days before the surgery. Direct oral anticoagulant medications like apixaban, rivaroxaban, etc. need to be stopped 48 hours before the presence of in the presence of normal hepatic and renal functions. If patient is on warfarin, then we might need a bridging therapy. In case of patients which are on high risks, like patients having mechanical cardiac valves and patient is having severe risk factor for any thromboembolic event. In these situations, tranexamic agent and hemostatic agents can be considered in patients undergoing urgent surgery with a high risk of bleeding, who are on antiplatelet agents or where a residual anticoagulant effect of these agents is suspected. Now come to intraphase. This is the phase where chances of maximum bleeding are there. So in this phase, we need to collaborate with the operating surgeon, the anesthetic involved, and the blood bank department. So now I will discuss all these points in brief, one by one. Antifibrinolytic. The tranexamic acid, which is the most commonly used antifibrinolytic, and the aprotinin, which is epsilon aminocaproic acid. These are synthetic lysine analog. Lysine amino acid is a weak inhibitor of plasminogen activation. It reversibly inhibits fibrinolysis by binding the lysine binding sites on plasminogen and limit the activation of plasmin, which cleaves fibrin strands. So basically, it is a clot stabilizer. Tranexamic acid is the antifibrinolytic properties of Tranexa were first described in 1966 in Japanese studies. It is a safe and inexpensive. It has minimal serious side effects even at high doses and with long-term use. There are sufficient and very strong evidences to exist to develop a perioperative guidelines for Tranexa used in many populations except patients with a history of thromboembolism. Relative and absolute contraindications are the patients with major comorbidities and the patients having history of previous thromboembolism, having allergy for Tranexa and other coagulopathies. Currently, tranexamic acid is the most commonly used antifibrinolytic in arthroplasty and other orthopedic procedures. The dosage of Tranexa is 20 to 25 mg per kg, which can be maximum up to 1.5 gram orally, or 10 to 20 mg per kg, which can be maximum up to 1 gram if we are giving it IV every 8 hours. This Tranexa can be administered by any route, intravenous, intraarticular, oral, topical, or in combination. Prophylactic use of Tranexa has been shown to reduce perioperative blood loss in all the major surgeries, including cardiac surgeries, orthopedic surgeries, gynecological surgeries also. The CRASH-2 trial. The CRASH here refers to clinical randomization of an antifibrinolytic agent in significant hemorrhage. This study was published in Lancet in 2010. It showed that early, which means within 3 hours of traumatic injury, early administration of Tranexa 1 gram followed by 1 gram infusion every 8 hourly significantly reduced the risk of death from hemorrhage and all-cause mortality in traumatic bleedings. And dramatically, the mortality rate rose if the dose was given after 3 hours. The recently published study in Lancet Hot IT trial concluded that Tranexa was not beneficial for GI bleedings. The second one is tourniquet. This is an appliance which is widely used during limb surgeries, and currently the use of a tourniquet is dictated by visibility of a surgical field because it reduces the intraoperative bleeding and makes the surgical field clear, which make it easy and convenient for the operating surgeon. because there are reduced tourniquet help to reduce intraoperative blood loss, but there is no difference in overall perioperative blood loss. There are a few disadvantages of tourniquet, like increased post-op pain, impaired local muscle function, mainly the quadriceps function, and increased risk of thrombotic events in post-op periods. Patients treated with multiple doses of IV and topical Trenexa without a tourniquet had less hidden blood loss in comparison to the patients which were operated with the application of tourniquet only. The benefits of Trenexa not debatable, but the use of tourniquet lies on the surgeon's discretion. The third one is Diatomian vessel sealing systems. These are monopolar and bipolar radiofrequency electrocauteries, and these are the key tools for achieving local hemostasis during surgery. Ultrasonic coagulating shears, titanium clips, plastic clips, harmonic scalpels, sutures for arterial and venous ligation are other things. Newer bipolar sealing systems are suggested to result in less damage to adjacent healthy tissue. The fourth one is closed suction drains. These are low vacuum drainage systems with a maintained pressure of 20 to 150 mmHg. The value of drains is specific to each procedure, and these are used primarily with the aim of reducing hematomas and surgical site infections, and are potentially able to decrease post-op pain and swelling. In orthopedic surgeries, conventional suction drains can increase post-op blood loss as it eliminates the tamponade effect of closed undrained wound. There are a limited number of robust studies that have investigated the effectiveness of drains in preventing post-op complications, and many did not demonstrate any benefit of drain insertion over no drain. Fifth one is ABTDs, autologous reinfusion drains, which focuses on post-op blood salvage. These are safe and effective methods and has been used for many years to reduce blood loss in total knee arthroplasty procedures. Post-operative shed blood is collected into the sterile canisters and reinfused after processing. The safety of reinfused unwashed orthopedic wound drainage has been controversial. If transfusion of blood has not begun within 6 hours of initiating the collection, the blood must be discarded. The use of post-operative autologous blood retransfusion drainage system results in higher post-operative hemoglobin level and less total blood loss. Sixth one is cell salvage. Intraoperative blood salvage strategies. That's very commonly and widely used in cardiac surgeries mainly. The method of recovering blood, it is the method of recovering blood from the surgical field during the intraoperative or immediate postoperative phase. It is useful when a high volume of blood loss is anticipated. Association of anesthetics guidance considered it to be greater than 500 ml. Here, the intraoperative blood is collected through a suction system. The collected blood is then anticoagulated, and the red cells are then washed and filtered and then reinfused into the patient. Blood collected during surgery is typically washed and resuspended in the normal saline before the infusion. When procedures with high volume blood loss are performed under tourniquet, postoperative rather than intraoperative cell salvage should be considered. Infections and malignancies were traditionally contraindicated to cell salvage previously, but with the use of leukocyte depletion filter, there is 99% reduction in bacterial contamination, and it has been established that reinfused tumor cells do not have any metastatic potential. Cell salvage reduced the risk of exposure to allogenic blood by 54% across all surgical specialties. There are few topical agents which help to minimize the bleeding in surgical field, like fibrin glues, filatin thrombin matrices, commonly available in the market with the trade name of Flocil, oxidized cellulose, available in the market as the trade name of Surgicel fibrillar. These are very expensive and there are very weak evidences of their clinical importance. Patient positioning is a very important factor to minimize the intraoperative bleed, because correct patient positioning is the simplest and effective intervention to reduce intraop blood loss, especially for surgeries in prone positions. Incorrect position can lead to compression of IVC with subsequent obstruction of venous return. Is in demonstrated to reduce blood loss in hip arthroplasty. The site of surgery should be elevated above the level of right atrium to facilitate venous drainage and to reduce venous pressures. Permissive hypotension, which is a very effective anesthetic strategy to reduce intraop blood loss. It is the lower intraoperative mean arterial blood pressure, which is 50 to 65 mmHg. It should be avoided in patients with coronary artery disease, poorly controlled hypotension, or cerebrovascular diseases. So adequate patient selection is paramount if you are dealing with this strategy. This can be achieved through a reduction in cardiac output, blood pressure, or a combination of these two. This translates into a reduction in transfusion requirement, mainly in orthopedic surgeries. Proper patient positioning, central neuraxial anesthesia, and several pharmacological agents like propofol, remifentanil, nitroglycerin, esmolol, dexamethasone, medetomidine, levotalol, sevoflurane, etc. are helpful in achieving permissive hypotension. Central neuraxial anesthesia, which is subarachnoid or epidural anesthesia, is the blockade of preganglionic sympathetic nerve fibers to arterial hypotension and reduce peripheral venous pressure. This results in less arterial and less venous ooze from the surgical site. It helps in attenuation of surgical stress response, which in turn is associated with stabilization of clotting factors and reduced fibrinolysis. There are a few ventilation strategies also, which is positive pressure ventilation with minimal use of expiratory pressure and low tidal volumes. We should avoid intraoperative hypothermia, which is defined as core body temperature less than 36 degrees centigrade. The vulnerable patients for developing intraop hypothermia are mainly pediatric and geriatric patients, and the patients undergoing surgery under combined regional and general anesthesia, patients undergoing major surgeries, prolonged surgeries, and patients with high ASA fitness grade. Regular temperature monitoring should be done every 30 minutes. Ambient theater temperature should be at least around 21 degrees centigrade, and we should use active forced air warming devices, and we should administer IV fluids through a fluid warmer. Desmopressin. This is a hemostatic agent and is a synthetic analog of naturally occurring antidiuretic hormone vasopressin. It causes a transient rise in plasma level of factor 8 and bone Willebrand factor. The ideal dose of desmopressin is 0.3 microgram per kg IV or subcutaneously. Contraindications of desmopressin are arterial or venous thrombosis, hyponatremia, and seizures. Recommended administration of desmopressin to patients on antiplatelet agents is advisable in many high-risk conditions. There are procoagulant factors which help to hemostasize the surgical bleeding. These are fresh frozen plasma, prothrombin complex concentrates, fibrinogen concentrates. These procoagulant factors are indicated in patients which are on anticoagulant therapy, and if there is history of significant bleeding, and if there is requirement of emergency surgeries in these patients. The risk of using procoagulant factors are potentialities to increase the rates of thrombotic events. There are available viscoelastic hemostatic assays like TEG thromboelastography and rotational thromboelastometries. These are increasingly being used in management of severe bleeding. These are the measurement of physical properties of clot. Current NICE guideline recommend the use of these assays only in patients undergoing cardiac and liver surgeries. The take-home message is that to minimize the surgical site bleeding, we need to have close collaboration between anesthetics, operating surgeon, hematologist, laboratory person, and the blood bank department. We need to identify and manage the high-risk patients, and we can minimize meticulous surgical techniques, achieving using tranexamic acid in pre-operative and interoperative period using regional anesthesia, and we must avoid interoperative hypothermia, excessive hemodilution. Optimal use of hemostatic therapies such as desmopressin, procoagulant factors, and the topical agents, blood transfusion devices, operative red cell salvage techniques are used. Usefulness of surgical drainage, etc. represent important area of ongoing clinical research.
जल्दी करो जल्दी कर दो इसको साइड कब किया एक पर फिर दोनों पर आ जाए अब पानी मत वहां से ले लो बस उधर ले लो मैं दूसरा भी कुछ ये मेरा लेक्चर है अभी इसकी तैयारी टीवी पर है सब ऑनलाइन काम रहता है I would request our chairperson Dr. Manju ma'am to honor our speaker.
So just a moment. Very good afternoon to everyone. Myself, Dr. Shashank, and when I was asked by Dr. Archana to deliver talk on this topic, I asked her what exactly she is wanting me to speak, and she said they have conducted some study recently, and they have found that out of all the transfusions that they are doing, 50% are for nutritional anemias. So she said this is a very stark and dark picture that this should not happen. Nutritional anemia should be treated by medical intervention rather than transfusion by improving nutrition or oral supplementation. So she wanted me to talk about what are the factors behind it, why have we failed it. So and I'm also told that the audience, there are hardly any gynecologists, 2 or 3. So this is a mixed audience. So I will try to keep my talk very general, very generic, more of an interactive one. If you want to ask, you can ask in between. So I'm not here to teach about the treatment of anemia. Everybody knows, ये लाइट बंद करें.
कि एम्स से बैठ के करना इजी है हमारे लिए डिफिकल्ट है बट जब तक आप अपने चैलेंजेस शेयर नहीं करोगे तो वी कांट फाइंड द सॉल्यूशन तो सर इज हियर टू गिव अ सॉल्यूशन एंड प्लीज शेयर योर एक्सपीरियंसेस एंड योर challenges also.
Solution to शायद I don't know, we all have to look for solution, but see, when I was doing my graduation 90s में, तो my teachers used to say कि अगर आप लोगों को anemia नहीं आता, then you don't deserve to pass. And I think it was justified statement कि उस वक्त data show करता था that 70-80% of Indian women were anemic at that time, and things have not changed much after that. This picture captures the global prevalence of anemia, and the irony in this picture is कि जो countries जितनी red हैं वो उतनी अच्छी नहीं, वो उतनी ही वहाँ पर population anemic है. I think the WHO people should reverse the color scheme in this. जो जितनी pale anemia को pale countries की तरह दिखाना चाहिए. So red countries, the prevalence of anemia is more than 40% overall population, not group wise. And India and South Asia in particular and Africa are really worst hit. 85% of all anemic women worldwide reside in anemia in India and in Africa. I'm sure everybody knows causes of anemia, and you have been told since morning. A lot of series of lecture have been there. So I'll just try to emphasize कि I ask my students, what are the causes? Can you classify the causes of anemia? They get confused. So to simplify, I would say, the bigger the circle, so most common causes of anemia, particularly in India and among vulnerable group like children or pregnant women, lactating women, adolescent girls, is nutritional deficiencies plus infections. And to emphasize and to underscore the etiological importance of nutritional deficiency की बात करें, so some people suggest कि हमें simplify कर देना चाहिए classification को nutritional causes and non-nutritional causes, so that the message is conveyed that nutritional causes contribute to nearly 60% of cases of anemia. और जब हम nutritional की बात करते हैं, so iron deficiency is the most common, but we should not forget vitamin B12, folic acid deficiency. I'll try to share experience of me later in the presentation to just convey that it's not just iron deficiency, although iron deficiency anemia is responsible for 50% cases of anemia in women. Little concept about spectrum of iron deficiency. Now, iron deficiency या iron spectrum की बात करें, so it begins on one end. There is an individual जिसमें iron stores बिल्कुल normal है and RBCs are also normal, and then because of long-standing negative iron balance, सबसे पहले stores में कमी आती है. There is no anemia, but stores are depleted. And the other extreme is when stores are depleted and the RBC mass also decreases. So जो anemia, iron deficiency anemia है, this is the far right on the spectrum of iron deficiency, when there are no stores left in the body. And अगर iron deficiency की, how does it develop? Because of long-standing negative balance. या तो demands बहुत ज़्यादा हैं, or there are more losses. Demands ज़्यादा हैं, for example, pregnancy, 1000 milligram is required. Lactation, a lot of iron is required. Losses ज़्यादा हैं. Girl enters puberty, menstruation शुरू होती है, heavy menstrual bleeding है, regular है, losses are more. Or there is helminthic infestation, worm infestation. Now, how does it affect health, individual health, as well as a nation's health? So if we talk about infants and children, it reduces their cognitive development. Now, when we say cognitive, एक simple हिंदी में अगर बोलूं तो सोचने और समझने की क्षमता, that is cognition. To think and to express your thought, to think and analyze things. So it affects their cognitive behavior, which can be seen as decreased concentration or perception. And if we talk about adults, it decreases their work output, the ability to utilize the energy. So you may ask, how does it affect a nation? Well, it has been estimated, even economists have spoken about it. वो कहते हैं कि 4% GDP decrease हो जाता है developing countries में because of anemia. Now 4% GDP हमें समझ नहीं आएगा कितना है. तो if I could give a figure in money wise कि how much India is losing every year because of anemia, it is close to 30,000 crore to 50,000 crore. ये मनरेगा का बजट के बराबर है या किसी छोटे मोटे स्टेट और मे बी छोटी मोटी कंट्री के बजट के बराबर. This is the kind of money that we are losing because of these cognitive losses and the physical losses because of anemia. This is annual. Now, this is I wanted to write intergenerational transmission of anemia, but maybe that conveys a wrong sense, but there is transmission of, so let's say a pregnant woman or a woman becomes pregnant, she's lower iron stores, she becomes anemic during the course of pregnancy. She's likely to give birth to a child with low iron stores and anemia. Maternal anemia is strongly associated with child anemia. So the baby will be born with low iron stores and hemoglobin levels, which is unlikely to be corrected in the coming years as an infant or as child, because most of these women will be from the underprivileged and underserved sections of the society. And that child is then going to go into adolescence, again with low iron stores. And then that girl will have onset of puberty, and there will be more iron loss in the form of menstruation. And then these adolescents, they enter the reproductive. So this cycle continues. This has to be broken at all possible levels. Now, in general, why women are more anemic, we all know there is increased loss when they start menstruating. 1 milligram extra is lost per day because 30 milligram is lost per cycle. Then there is increased, there are physiological states where there is very high demand of iron, as in pregnancy. Extra 1000 milligram is required in one singleton pregnancy. Now, why Indian women are overwhelmingly anemic? There is a recent study which concluded that Indian women are 3 times more anemic than any other country with the same kind of development. We are not comparing with the developed world. Same kind of development, Indian women are 3 times more likely to be anemic. In fact, the absolute number of anemic women in the world is most number of women, anemic women are in India. And I think the most important reason is dietary practices. Hamari bad dietary practices. What are those bad dietary practices? Majority of our population, they eat cereal-based or grain-based hamari diets. Problem kya hai? That first of all, the diet itself is not sufficient. Second, the kind of iron there is not enough. Non-heme iron, cereal-based, grain-based mein iron content kam hai, number 1. Second, uski absorption is even lesser. So when we compare it with the heme iron, which is from meat, poultry or fish say, uski absorption kareeb 10% hai, or this non-heme iron ki absorption less than 5%. So again, reiterating the same facts, cereal-based or grain-based diet mein, the content of iron is less, the diet itself is less, the absorption even lesser. And then other factors, iron ko absorb hone ke liye enhancer chahiye, for example, acidic environment chahiye, to vitamin C, वो भी कम है उसमें. और हमारी प्रैक्टिसेस ऐसी हैं कि साथ में चाय पिएंगे या कॉफी और मे बी दूध लेंगे, उसमें इनहिबिटर्स हैं. So all in all, very bad dietary practices. Then we have certain social customs. For example, most of the housewives would will take meal at the end when everybody in the family husband has taken, children have taken. और most of the time तो left over खाएंगी. So खाना सबके लिए एक बराबर बना था, एक खाना बना है, लेकिन उनके हिस्से कम आएगा. So, and this is maybe as a middle class, upper middle class, we don't see these things, but there is a law section, 5th, 6th. I was reading today in the morning, 60% of our population earns less than 100 rupees a day. ये आज का कहीं article. So these are facts. Then they become pregnant at an early age, then there are repeated pregnancy, short inter-pregnancy intervals, and this vicious cycle goes on. So coming to the strategy, how to prevent iron deficiency. So my most focus is mainly on IDA. So what are the strategies? So as we have discussed, anemia is a multifactorial disorder. So strategy is multi-pronged karni padengi. And the first and foremost, as I said, dietary practices. So isliye first and foremost and most important and long-term and sustainable is food-based approaches. When we say food-based approaches, dietary diversification. This needs behavioral change on part of population. Well, I will not go into the details of it, but this is very, very important to tackle the anemia in long term. Dietary diversification. Or jab tak ho nahi pati, so it's not easy to change behavior overnight or even, soon. So food fortification, iron-rich foods. Government of India is doing that. And फूड बेस्ड अप्रोचेस के साथ I hope everybody knows IFA, iron and folic acid supplementation and deworming. And then we need improved health services to diagnose and to monitor and to treat these anemic women. Now let's take a look at the IFA supplementation program of India. India was the first country which launched a program to tackle iron deficiency anemia as long back as 1970s. तो 50 साल से हम सप्लीमेंटेशन प्रोग्राम चला रहे हैं. सबसे पहले anemia prophylaxis program 1970 में, then national nutrition policy was launched in 1993, and based on that national plan of action on nutrition was launched in 1995. Then 2013 in UPA2 national iron plus initiative was launched, and in 2018 anemia मुक्त भारत campaign was launched. So बहुत सारे program launch हुए हैं, very catchy sloganeering, a lot of money has been spent on these things. And just iron plus initiative में क्या change आया? Just a few words. इससे पहले iron plus initiative से पहले जो nutritional programs थे वो target कर रहे थे बच्चों को, children को, और pregnant women को और lactating women को. So जो non-pregnant या non-lactating थी उनको include नहीं किया गया था, और जो adolescents थे उनको include नहीं किया गया था. तो इन दो groups को इसमें include किया. The idea was to target the population throughout the age from 6 months to लेकर 50 या 60 years तक. So ये दो ग्रुप ऐड किए गए और इनको आयरन फोलिक एसिड सप्लीमेंटेशन डीवॉर्मिंग उसके डोजेज अलग हैं, वो WHO के रिकमेंडेशन पे बेस्ड है. So again targeting all age groups. That was National Iron Plus Initiative, adding 2 more groups. Now let's take a look. 50 साल का कैंपेन है. How have we fared? Where were we and where are we now? This is data from National Family Health Survey. National Family Health Survey 2, 3 and 4. जो NFHS 5 है वो was supposed to be like out by this time, but because of COVID, some data is there. I'm not very sure, but it got delayed because of the COVID. So अगर आप under 5 children में देखें तो there is a decrease in anemia prevalence, but still very high. But look at pregnant women, lactating women, and women of reproductive age. Anemia जहां था वहीं है. It is stagnant, above 50%. And let's look at this limited data that we have. NFHS 4 and 5 का for adolescent girl. यहाँ तो चीजें और भी गड़बड़ है. The prevalence 22 states में से, see, this is blue depicts decrease in prevalence. This brown depicts increase in prevalence. Out of 22 states, 16 states में adolescent girls में prevalence of anemia has increased from NHS 4 to NHS 5 survey. So it's a failure of IFA. I take it as a failure of IFA supplementation program. 5 decades, lots of money, lots of billions of doses distributed. The question is why? There are no simple answers, but let's try to understand. जो मुझे समझ आता है, to understand, let's go back to the physiology of pregnancy. What are iron requirement in pregnancy? So dietary iron, let's see, every person should take about 18 to 20 milligram of dietary iron every day. So let's assume somebody is taking 20 milligram of iron. 10% will get absorbed. Pregnancy में iron absorption वैसे भी बढ़ जाती है. So that person will get about 2 milligram of iron every day. Now the iron requirement of pregnancy क्या है? So in early half of the pregnancy, it is about 2 to 3 milligrams. So you can see that dietary iron will be sufficient. When I say early pregnancy, it means before 20 weeks. To be precise, 24 से पहले, this is the requirement. After that, there is a sharp increase or jump in the requirement of iron. It comes out to be 6 to 7 milligram. Why? Because the RBC mass increases. So in a pregnant woman, let's say a non-pregnant woman, there is hypothetically, let's say there are 100 RBCs, total number of RBCs, 100 हैं. So by the time she reaches 9 months, 30 more RBCs are added in her peripheral circulation. So उसके लिए iron requirement है. 500 milligram तो RBC expansion के लिए चाहिए. फिर बच्चे की भी growth हो रही है, placenta की भी हो रही है, 500 वहाँ चाहिए. So this jump actually RBC expansion and the fetal growth picks up in the later half of the pregnancy. So the iron requirement भी suddenly jump कर जाती है. So 6 to 7 milligram डाइटरी से आपको 2 मिल गया, so आपको supplementation की कितनी जरूरत है? 30 to 60 milligram. That is what WHO also says. So later half of the pregnancy, early half of the pregnancy, you don't need supplementation. This slide is conveying that. In the later half of the pregnancy, you need 30 to 60 milligram of supplementation. One few more facts to understand. Ab early part of the pregnancy, 80% of the pregnant women, 100% of the first time pregnant women will have nausea and vomiting of pregnancy. They can't tolerate anything. They can't tolerate anything. They can't even tolerate smell of food sometimes. Some women can't tolerate smell of food also. So, and I've seen prescriptions jahan first trimester mein iron start kar diya gaya. So they won't, even if they were able to retain something, aapne iron start kar diya, they won't be able to retain anything at all. Gastric emptying is delayed. So more the stay in stomach, more the tablet will irritate this mucosa. And in most of the women, a large majority of the women, ये nausea and vomiting 12 हफ्ते पे खत्म हो जाता है. And majority के बाद most में by 20 weeks it gets over. So iron demand भी आपकी 20 weeks के बाद ही बढ़ रही है, जो diet से sufficient पूरी नहीं हो पा रही है. And nausea and vomiting, these physiological changes are also over by 20 weeks. So it makes sense to supplement, give iron folic acid prophylaxis after 20 weeks. Now, why has Iefa failed? Probably, see, Government of India, जो Iefa इसका charger. I believe one of the factors have been this 100 milligram tablet. I used to ask myself why the government is giving 100 milligram. Market में जितनी भी preparations हैं, majority are 30 milligram. कुछ preparations 60 milligram है. Why the Government of India launched? अभी शायद probably 60 milligram कर दी है. They have also woken up late. So I used to ask why have they, 100 milligram की जरूरत नहीं थी. So होता क्या है 100 milligram से? We know the side effects of iron. I don't know how many of you have taken, but those who have taken must remember. Would have remembered most common. GI side effects are most common, and it is a deterrent to continue. And 100 milligram के साथ GI effects are very strong. So the NFHS survey में ही ये देखा गया है that the uptake is very poor. Pregnant women में सिर्फ 20% women थी जिन्होंने उसको 90 दिन से ज़्यादा pregnancy में iron folic acid लिया है. 100 milligram 100 days के लिए देते हैं. Only 20 women took it more than 90 days. Such is the compliance or adherence or uptake of Iefa supplementation during pregnancy. And probably the reason is, one is the GI side effects with 100 milligram tablet, and kind of quality that's not to be commented. So this dose needs reduction. And second, probably वो counseling नहीं होती है कि how to take, when to take, dietary practices कैसी हैं. So what I practice this in my daily practices or OPD, I never give iron if patient is not anemic. I will never supplement before 18 to 20 weeks. I wait till 18 to 20 weeks. And then I start supplementation, and we do write prescriptions. So I believe in maximum 60 milligram for prophylaxis, not more than that. And if women report side effect with that, I would ask her to take it alternate days or at least twice a week. And this is not based on my personal experience. The studies have shown, there is a recent Cochrane systematic review and meta-analysis. It has shown that the tolerability of Iefa and adherence is more if you give it infrequently, not daily. And side effects, both, and these women are unlikely to become anemic in pregnancy. So this is something I wanted to convey strongly to the audience, that Iefa prophylaxis, iron pregnancy mein, I don't believe in starting before 5 months, 18 to 20 weeks. And if the woman is not anemic, and it should, then you have to counsel. It takes 30 seconds to counsel. Ideally, iron should be taken empty stomach, because acidic environment mein iron ki absorption better hoti hai. But I think that's not a very practical thing to do. So I ask my patients to start taking iron after meal, at least 1 hour after meal, not with the meal, but this will irritate the stomach less. And at bedtime, because even if it thoda bahut discomfort hoga, to neend mein pata nahi chalega. So at bedtime, after meals. Then coming to last few slides, 2-3 slides, I didn't touch upon much of the management of anemia. What I wanted to convey, see, with this slide, I want to emphasize that there is no shortcut for any disease. Clinical workshop should be, history and examination. To elaborate the point, I'll just share my experience when I was an SR. I was on rounds and I see a young patient who was admitted 2 days prior with incomplete abortion. She underwent dilatation and evacuation, and her HB was 4 gram/cell. She received 2 blood transfusions, and it was assumed that this anemia was because of acute blood loss. So I took her history. She was hardly 6 weeks. 6 weeks पे अगर वो abort करती है, इतना blood loss नहीं हो सकता. Uterus is hardly the size of a cricket ball. इतना blood loss नहीं हो सकता कि वो 4 ग्राम पे पहुंच जाए. So I felt there is something missing. So I examined her and I did this general physical examination. She was jaundiced, deeply jaundiced. The next thing I wanted to do was I palpated her spleen and liver. She had massive hepatosplenomegaly. So then I referred her. So any situation, clinical workup is must. Then coming to, this is the least investigation that I do in my patient. I don't stop at HB. I would do this much investigation, any patient, whether it is mild or more than that. And to again give a personal example, recently my sister-in-law called me. She's a bank official. Her husband is a bank official. She's 5 months pregnant. And she told me that she WhatsApped to me that she's anemic and she has been started on iron folic acid, treatment. She was already on Iefa. She was diagnosed with anemia. I simply asked her to share her her tests with me. So she shared, this is actual what she shared with me on WhatsApp. So her HB is 10. We all know in pregnant state, less than 11 is anemic. What her treating physician did not notice was MCV is 97 femtoliter. This is on the higher side. And she was being treated with anemia. So I told her that I want a peripheral blood film. So next thing she got me a peripheral blood film and it showed there was macrocytosis. So I see iron deficiency was strongly out of suspicion, but just to ensure that I'm not missing something, I got ferritin levels done. And ferritin levels less than 15, less than 30 is still, you can debatable, but less than 15 is deficient. This is very normal range, 63 nanogram. So my suspicions for vitamin B12 deficiency was strong. And by that time, she had already read about it and she got her own vitamin B12 done. It's a costly thing and it was deficient. So again, everything cannot be assumed to be iron deficiency. Although my talk has been on iron deficiency anemia, but everything cannot be, So we have to, this is the least investigation that I do. And if I find something confusing or I'm unable to make a diagnosis, then I'll go to some further investigation. Although I have written as special, but I don't think so there is anything special. In here, we routinely advise serum ferritin. So serum ferritin is another investigation that we routinely employ. And mark my words, at least before you give parenteral iron, I require serum ferritin. Conclusive evidence that there is iron deficiency. And I'm going to pump in iron into the veins, or so before that I need a serum ferritin levels. Okay, I'll just finish. So take home message: anemia is a serious public health problem in India, and there has been a stagnation or even increase of anemia prevalence in MNHs 4 to 5. And since the causation is multifactorial, major causes are nutritional deficiencies and infections. So we need to shift from nutrition only or iron folic acid supplementation to cause-based specific approaches. Thank you. Any questions?
Important, and especially for the country where all the facilities are not available. But simply, just giving the right advice to the patient regarding the iron and all this. Anemia in the pregnancy can easily be controlled.
Thank you.
I request our chairperson, Dr. Devraj sir, to honor our speaker, Dr. Shashank sir. Thank you, sir. Now I humbly request Dr. Archana Bajpai ma'am to felicitate our honorable chairpersons, Dr. Manju Vora ma'am and Dr. Devraj Arya sir. Thank you, sir. Thank you, ma'am. Thank you to all the speakers and chairpersons for this very elaborate session. With this, we come to the conclusion of this scientific session on anemia management. I request everyone to disperse for lunch and assemble back by 2:45 p.m. for the next scientific session on bleeding and trauma management. Thank you.
कुछ भी डालना बैकग्राउंड में डाल
जो 03 करके मेरा लिखा है उसको डिलीट कर दे। ठीक
अगर वो ऊपर आ तो यू आर स्ट्रीम शेयरिंग होगी। लीव तो नहीं करियो तो पाँच को तो हो जाना।
पांच लड़की थे और नो और लाल कलर है जी थोड़ी आयोडित है
ये किसका आ रहा यार। ठीक है
है ना
कोलेस्ट्रॉल पूरे नहीं
शेयरिंगली वो तो हट जाते हैं।
चल ठीक है।
देनी वो नाम भी क्या है
चलो।
इन लैपटॉप वाला रहना
उसके जरिए और
ले ले ड्रॉ लॉक कर दूंगा।
माया 20 स्लाइड ही है, जल्दी हो जाएगा मैम।
मैं रख दूं सर। मैम हाँ सर
Recording in progress.